in one spot, so I'll have to keep running back to the computer. I know I need to use the mouse to point because we've got two screens. So the rules of engagement are, if you don't understand something or something's not clear, and I hope that's not the case, but it may be, please holler out so that you can get my attention. I'll try to take a break as I move from one section to the next and answer any questions. The next order of business is I'm really happy today because the Spurs won last night, and it looks like we're going to the NBA Finals again, which is fantastic. Number 3 is some house cleaning information. In your section on oncology in your folder, I can't call it a handout because it's ginormous, but in that section on oncology there are 5 different sections. The first 3 will cover the slides that we're going to do today. Introduction to Orthopaedics, and then the bone lesions and the soft tissue lesions. Section 4 is an informational handout that's included that one of my chief residents some years ago put together, and actually has very good information in it that I try to keep current. And I wouldn't spend time reading that or studying that for your boards unless you're interested in doing so. It's got good information I think will help you as you're going into practice, but I wouldn't take the time to read it if you don't feel like you have the time. Section 5, however, is something you do need to read. That's so-called Parsons Picks. This is something I started years ago for my residents in the in-service, and it's kind of expanded. This is just jotting down my notes or typing them down about the different lesions. If you will read that before you go take your boards, I can almost virtually guarantee you'll know the answers to all the questions that are asked. As a matter of fact, one of my chief residents who's here ran into one of the fellows at downtown in San Antonio who said, you know, tell Parsons I got every single pathology question right last year. Did he write all the questions? And the fact of the matter is I didn't write all the questions last year, but I know the kind of questions that are asked. So if you read that, you'll do fine. So let me put your mind at rest right now. Pay attention what I have to say. Read through that, and you will do fine on the pathology. I absolutely guarantee it. Every year I get lots of people telling me I did fantastic and I knew nothing about pathology. So just relax. I'll try to make this enjoyable and educational. And lastly, in the front of your big old binder is a disc. By popular demand, people were saying, well, what about, and what about, and what about? So finally we have the what about. It's there in a CD-ROM for you that you can open up, look at some representative imaging studies, and look at the histopath as I show it up here on your own computer. So you've got it in color, and you can look at it and review it. As well on that disc are some review questions and some exam tips, the very last thing that you can you can use to test your knowledge and go over the information. So hopefully everyone's happy with that, and you'll be able to use the information to be prepared. So I'm pretty confident that things will go fine. Are there any questions before we get started? All right, I can see it's a real lively crowd today. I have to admit that Mark has lots of chutzpah. He puts tumors and spine first day all day long. And it's kind of like the 3rd grade primer, Johnny's very bad, horrible, miserable day at school, to put tumors and spine together. However, but you have to understand that the only reason it's miserable is because there's spine on there. The tumors have nothing to do with it. Tumors are great. All right. So we're going to cover the basics this morning. What you need to know, but probably didn't want to know, and you're only putting up with it because you have to take a test in a few weeks that says you got to know a few things. I was privileged to train at Harvard a number of years ago with these people. For those of you who don't know, this is Dempsey Springfield, Henry Mankin, and Mark Gebhardt. All 3 are, well, he was chairman at Harvard, and really great guys, very bright. Some of you actually may be here from Mount Sinai where Dempsey is, and Mark is still in the Boston program. Okay. Musculoskeletal neoplasia are rare. You're not going to see them very often in your practice, maybe 1 every 5 years or so. You will see, however, metastatic carcinoma, which is about 100 times more common, and you'll see relatively frequently in your practice. Consequently, on your board exam, you will clearly see metastatic carcinoma there. There'll always be a few questions on that. And remember that benign lesions are far more common than malignant lesions. Cases are missed in working up tumors because the clinician doesn't think of the possibility. They just completely blow it off. Or the answer is, the knee-jerk response for the family practice guy, oh, it's a lipoma, it'll go away. Or it'll go away, don't worry about it. Everything should be considered potentially malignant and should be investigated unless it's very small, superficial, and it can be followed. But don't make assumptions without information. This kid here had this big mass on his thigh that was followed by a board-certified orthopedic surgeon for several months because he said, well, it's myositis ossificans. He took a football helmet in the thigh. Well, the problem was there was no ossificans on the film. I mean, it was just a big soft tissue mass. There's no mineralization at all, which we'll talk about later. I'll show you some examples. So you just can't make assumptions. So when we talk about nomenclature, let's just very briefly go over this. We won't spend a lot of time on it. Malignant bone tumors and, of course, benign bone tumors. And here's some examples. Osteosarc, chondrosarc. Tumor-like conditions, which you kind of refer to as tumors, but they're not really necessarily. And, of course, metastatic disease. Soft tissue is the same way. Benign and low-grade lesions and high-grade lesions. Here's some examples of the typical ones. We're going to cover most of these. And then, of course, we split them out specifically when we talk about bone, fibrous tissues, and so on and so forth. So again, benign lesions include osteoid-osteoma, benign osteoblastoma, osteoma, and so on and so forth. This is basically for your information. Fibrous lesions of bone. Notice that I've got some asterisks by this thing. MFH, which we're all very familiar with or have heard the term a lot, the pathologists are no longer calling it MFH. It's now high-grade sarcoma not otherwise specified. So high-grade sarcoma NOS. I think for your board purposes, you're still going to see MFH, all right? But in a year or two, that's probably not the case. It'll probably be high-grade sarcoma not otherwise specified. So that's just kind of an FYI. Cartilage lesions, these are the bane of our existence because they're difficult to treat and difficult to diagnose sometimes. But again, if it's making cartilage, it's benign or it's a chondrogenic lesion, malignant or benign. All malignant chondrogenic lesions are, of course, chondrosarcoma, and there's various and different sundry types. And then unknown lesions here. We're going to cover the vast majority of these things, and some miscellaneous. Again, here's another one that's changed. Hemangioendothelioma, the pathologists don't call it that anymore. It's now solitary fibrous tumor. But again, for your purposes, I wouldn't worry too much about it. And then classified as typical low-grade and high-grade lesions, and same thing with soft tissue. So I've got these listed in here just so you get an idea of how things are separated for nomenclature. It's important for you to recognize that sarcomas are not carcinomas, okay? Sarcomas, deep tissue malignancies, are not carcinomas, which is what Aunt Millie had because she had breast or lung or whatever. The carcinomas, of course, are lining cells. The sarcomas from the deep tissues. They are much more aggressive than sarcomas are. They grow rapidly in a sort of centripetal or outward fashion. They usually respect fascial planes, but they'll fill up compartments. Not always, but usually respect fascial planes. And they metastasize pretty easily. Lung, bone, and liver are pretty common. And, of course, they require aggressive treatment, typically with surgical and adjuvant modalities. Here's this kid that I showed you, a modified hemipelvectomy for what turned out to be a very aggressive leiomyosarcoma of his thigh. All right, so we're going to talk about staging. The days of just knowing how to stage a lesion for your board exam are gone. The examiners expect you to know what the stage is and then to apply it. But you got to understand the stage, and we'll briefly cover that this morning. Every year, someone comes out to me afterwards and says, now, I'm confused on stage and grade, and I'll try to clarify that. When you talk about the stage of a lesion, it is sort of the overall picture of how bad it is. And it takes into account the radiographic appearance, how much is spread, what the grade or how bad the tumor cells look. So all those lumped together are the stage. When we talk about the grade of a tumor, you're talking about histologically the pathologist looking at it, looking at the cells and saying, oh, this is high grade because it's got a lot of polymorphism, there's necrosis, and blah, 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 blah. All right? Hopefully that's very clear in everybody's mind. We stage lesions, so it will help us kind of evaluate apples to apples to identify treatment and to identify prognosis. And what we use mostly is the Enneking system, which includes benign Arabic and Roman numerals for both benign and malignant systems. I know you all have seen this. We'll just cover it very briefly. So again, the staging system for Enneking is stage 1, 2, and 3, Arabic, which are benign. Inactive lesions, active lesions, and aggressive lesions. So an inactive lesion might be an inactive cyst that's been there for a while. An active lesion might be a non-ossifying fibroma in a young kid. And an aggressive lesion might be a giant cell or a chondroblastoma. Everybody gets that idea, but they're all benign. Malignant, of course, is stage 1, stage 2, and stage 3 for low grade, histologically low grade now, the cells. And it can either be intra or extracompartmental, A and B. Higher grade, again, intra or extracompartmental. And then stage 3 is any grade, but it's spread. And of course, that's a worse prognosis. Even if the pathologist looks at it and says, well, Dr. Parsons, this is a relatively low-grade kind of sarcoma you're looking at. And I said, well, thank you very much, Dr. Y, but he's got mets all over his lungs and all over his femur. It's not behaving as a low grade, and hence the stage 3 has the worst prognosis. So here's how we stage them, of course, in this chart. 1A and 1B. So these are low grade for malignant, intra or extracompartmental, high grade malignant, and any grade with regional or distant metastases. And these are the compartments. You don't need to memorize them, but it's pretty clear that some spaces like intrafascial components, posterior calf, anterolateral leg, anterior thigh are pretty well confined compartments, whereas extrafascial planes or spaces like the popliteal space, the groin, the intrapelvic and all are extracompartmental. There's nothing to contain it. It's easy to take a tumor out of an anterior thigh because it only stays in the anterior thigh usually. But if it's in the groin, it's not contained anywhere, and it kind of crawls into the thigh and crawls into the pelvis and so on and so forth. So here's just a cartoon, which is borrowed from Bill Enneking's stuff. This is bone now, stage 1 or latent or inactive. It's just kind of sitting there, fat, dumb, and happy in the bone. An active lesion, which usually has some response around it from the bone, and of course a more aggressive lesion that's trying to break out of the bone. For the malignant lesions now, it's again the same cartoons. Here's bone and soft tissue. This is low grade, sitting inside the bone, not broken out, in the soft tissue, in the compartment that's got this reactive zone around it. Higher grade, of course, breaking out and extending beyond the compartment. And then here's just an example of the compartments in your handout. So one of the questions typically that has been asked in the past, but you should commonly think of, is that osteosarcoma typically presents as a stage 2B lesion. It's high grade histologically, and it's typically extracompartmental, as you see in this MR here. The lesion here inside the bone and outside the bone. It's bad. Something's crawled from inside to outside. You know it's malignant, and it's a high-grade lesion histologically. The AJCC staging system is something that you need to be familiar with only because it provides us some information, number one, how the hemonc people think, but number two, it provides us information about size, depth, and grade. And I'll show you that in a summary slide in just a minute. But just to let you know that these stages on the AJCC system, which we don't use as orthopedists, but the hemonc people use frequently, and they're not that familiar with the orthopedic system or the MSTS system, so they'll be talking to you this way. Same thing, stage 1 to stage 4, lower to higher grade, and notice that the difference is size. If it's small, okay, low grade is number 1, higher grade but small is better than higher grade but larger than 5 centimeters, and this is superficial now. Then if it goes larger than 5 centimeters, then it's deep, then it's the next stage up, and then finally if it spreads. So you're going from low grade to high grade, size, depth, and grade of lesion. They also have a bone one that I've thrown in here just for completeness sake. I wouldn't worry too much about this except same thing, grade and size of lesion. That's just mostly for information. But here's what you need to know, because this is the kind of thing you get asked about in terms of staging. The prognosis for soft tissue lesions is basically dependent upon the grade. Remember, that's the histology. How bad are the cells looking and acting? The size. Is it 5 centimeters and more or smaller than 5 centimeters? And finally, the depth of the lesion. Superficial, of course, being better than deep. So if you have something that's high grade, larger than 5 centimeters, and deep, which would make it a stage 3, overall survival is about 50-50. If they present with metastases, overall survival is only about 30%. So you see, you get the idea of why we stage people to understand how they're going to be, or how they're going to do, how aggressively you need to treat them, and so on and so forth. Okay, any questions on staging? Kind of takes in all the information together and helps us determine where the person is and how they're going to do. So working this person up, we're looking for what? Soft tissue masses, of course, which is what brings it to the people's attention, or perhaps pain, overlying skin changes, and it's always important to check for adenopathy. So do a good general musculoskeletal examination, and if you're thinking about metastatic disease, don't forget you need to look at, examine, or work up thyroid, abdomen, prostate, and breasts. For clinical presentation, pain is a very important aspect, and these people will say, yes, it hurts. It's usually dull-seated toothache-like pain that is getting progressively worse. And constantly, or typically rather, people will say, it hurts me worse at night. You have to ask patients, does this awaken you from sleep at night? It's one of those red flags that should be waving that recognize that something is bad. It may not turn out to be bad, but it's a red flag. The other thing you need to ask is, what do you take for pain? Because if you see a person that come into your clinic and they say, well, it doesn't really bother me, Dr. Parsons, and you say, okay, that's fine. And then you look at their meds chart and they're taking, fentanyl patches, Percocet and Darvocet and morphine, well, no wonder they don't have pain. They shouldn't even be conscious. But if they say, well, no, I don't have to take anything for the pain, then you say, okay, maybe it's not so bad. So requiring narcotics for pain control is also another red flag that you need to be aware of. This gal here actually was a gal that I treated a number of years ago, pregnant, very beautiful gal with her first child who we thought had giant cell tumor based on a little biopsy. It turned out that she had horrible metastatic disease and didn't survive the pregnancy. It was just really a depressing thing. So the next thing we do now, we've done the physical exam, we've kind of looked at what's going on, taken a good history, we have to go to the radiographs. This is important for you because this is what's going to help you pass your test by understanding how to interpret the radiographs that you're shown. Bill Enneking has his so-called Big Four, which I'm sure all of you have heard because his teachings are so pervasive in orthopedics. Where is the lesion? In other words, anatomically, where is it located? Metaphysis, diaphysis, epiphysis, etc. What is the lesion doing to the bone? Is it destroying the bone? Is it doing nothing, etc.? What is the bone doing to the lesion? Is the bone walling it off and saying back, 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 back? Or is it doing nothing? There's no reaction at all by the bone. And then finally, are there additional clues? And by that, we typically mean, is there a matrix in it? Is it mineralized? Is it calcified somehow, etc., which will give you sort of an idea of what's going on. So those are the kind of questions you need to ask yourself when you look at the radiograph. So in this case, for example, here's something that this is diaphyseal sclerosis. This looks pretty innocuous. What's the lesion doing to bone? It's really not doing anything. What's the bone doing to the lesion? Well, it's making bone, all right? But really nothing else going on. Over here, the bone is responding to this, this is a sclerosing osteomyelitis of Garay. Here the bone is responding because it's expansile slightly. It's creating new bone around this lesion, and the lesion's irritating the bone itself to make it respond. This is a good time for me to interject that bone knows one trick. This is the Henry Mankinism. He said, my dog Fido can roll over and play dead, but that's all it can do. If I say beg, it rolls over and play dead. If I says sit, it rolls over and plays dead. Bone knows one trick. If it gets pissed off, it makes bone. That's all it will do. If it's infected, it makes bone. If it's a tumor there, it makes bone. If it's fractured, it makes bone, which is good for us. That's why we have a living. And so on and so forth. So anytime you see bone being formed, something is not right. Now, it may be that it's a stress fracture, or it may be that something else more pathologic is going on. So recognize when you see bone somewhere, something is happening to irritate the bone and cause it to respond. Let's see, did I skip one? Here we go. So here's an example of a lesion that's diaphyseal in location. What's it doing to the bone? Well, it's kind of destroying the bone. Remember, 50, 60% of the bone mineralization has got to be gone before we can see it radiographically. All right? What's the bone doing to it? Well, really not much. There's not periosteal reaction. There's not expansion around it, so on and so forth. So this is sort of sitting here, and the bone's not responding to it. This is an example of an eosinophilic granuloma, an EG. Don't worry about that. We'll talk about those specifics of those things later when we go over the particular lesions. And here's another one. Everybody recognizes this as a simple cyst, that it's sitting in the bone. It's actually erosive around the bone, but the bone's not really responding to it either. It's not making bone around it. It's not got periosteal reaction, and so on and so forth. These will all kind of help you. Here's an example inside the proximal femur in the neck. Anybody virtue to guess what this is? This is one of those ant minis. You look at it and you say, I recognize that. This is a fibrous dysplasia. You'll see lots of fibrous dysplasias in the proximal femur that look this way, sort of sclerotic or mixed sclerotic lytic pattern, very common. Again, it's irritating the bone enough to make bone here locally, but nothing else going on around it. Here's something now that's expansile to the bone. It's lytic, expansile. The bone isn't making much a response around it, but it's enough that it will cause the expansion of the bone. So this kind of gives you an idea. And here's pretty clear, something that's aggressive, breaking out of the bone, and the bone is impending pathologic fracture. This is a MET. So that's kind of how you look at radiographs to give you an idea. And as we go through, I'll give you clues. Epiphyseal lesions, for example, are almost always giant cell tumor, chondroblastoma, or perhaps clear cell chondrocyte. That's one of the lists that you should be able to spit off that my residents can do, as opposed to metaphyseal lesions or diaphyseal lesions. Henry Mann cannot be outdone by his good friend and sometimes nemesis Bill Enneking, has his own 4 questions about radiographs. And that is the lesion big or small? Is the cortex intact or not? Is the lesion marginated or not? And is there a soft tissue component to it or not? And this is not so much as a discussion of what is the lesion, but is the lesion good or bad, malignant versus benign. So a big lesion that is not, that the cortex is not intact, is not marginated, and there's a soft tissue component, we'd say, yeah, that's probably bad. It's probably malignant. And just an example, here's something, this is a metastatic renal cell in the pelvis. The bone's melted away, there's soft tissue, it's not marginated, and the cortex is gone. Here's a post-radiation sarcoma that has got a soft tissue mass here, it's not marginated, and the cortex looks funny here, probably from the previous radiation. So helping you describe or identify good and bad is asking yourself these questions. And here's a good one here, kind of a washed out appearance, something's not going on, has sort of this lytic appearance here. We think there's a soft tissue mass here, and confirmatory on a cross-sectioning image, you can see the thinness of the bone, soft tissue mass. Is this good or bad? It's clearly bad. Now, if you had a picture like this put up in front of you for a young, let's say the person is 20, 18 or 20, what would your diagnosis be? You get no other information. I put this picture up. We've just decided it's bad. What's the diagnosis? Okay, everybody should be saying osteosarcoma in their mind, right? So another mechanism is that when you see these destructive lesions about the distal femur proximal tibia, you get called on around, you walk up to the board, you look at it very carefully, then cover your eyes and say osteosarcoma 3 times and Ewing's once, and you'll probably get the answer right. Okay? So the questions that you'll see on your in-service, sorry, not your in-service, on your board exam, you wish it was in-service, right? Maybe you don't. You don't want to go back another year. On your board exam are not designed to trick you. And you're going to see the common types of things presented to see if you recognize them. You will see an osteosarcoma, and you'll almost always get that answer right because you'll say, yeah, Parsons said destructive distal femur, soft tissue mass, probably an osteosarcoma, and it probably will be an osteosarcoma. So you got to remember that the radiograph is the gold standard for establishing diagnosis of bone lesions. It's not the bone scan, it's not the MRI, it's the plain film. So that's why, by and large, most of your tumor questions will have plain films on there. Unfortunately, most of the rest of the world, the knee-jerk response from the family practice guy or the pediatrician is, something's wrong, get an MRI. And they show you this MRI, and you say, well, you need a plain film first. In two planes, radiographs. Don't accept bad quality radiographs, or if you do, document that they're bad. Because if it's underpenetrated and you can't see the fluffy mineralization there, and you say, it looks okay to me, you've just made somebody's lawyer very happy. And if it's overpenetrated, the same thing could be. So get a new radiograph that you're comfortable with, or at least write clearly in your chart, I cannot read these films because they're poor quality and I don't have the capability of doing it, so you can at least give yourself something to fall back on. Who would like to guess what this is? The first person thinks, somebody, Paget. You'd think, so this cotton wool exudate's a Paget disease, but it's not that, although that's what I would guess too if I was taking my test. This is actually metastatic osteosarcoma to the skull. Very bad. Okay, the last thing about radiographs that we're going to talk about is the Lodwick classification. This is still helping you look at the radiograph and interpret what's going on, all right? This is not staging. This is not grade. This is a Lodwick appearance or Lodwick classification or Lodwick stage, if you will. I use the term loosely. I don't want to confuse you. To help you identify what is going on with the bone. And it's very useful. both as a diagnostic aid and for prognostic information. And there are 3 types, type 1, 2, and 3. Type 1 is geographic. So a geographic lesion can be subtypes A, B, and C, which means it has a sclerotic border, a distinct border, or an indistinct border. So here's an example of type 1A, geographic lesion with a sclerotic border. All right? This is a fibrous dysplasia. I'll give you that one here around the proximal tibia. What is this around the distal tibia and metaphysis? Everybody should be thinking non-ossifying fibroma. By the time you're done with this lecture, you'll all know that right off the top of your head. But again, this pretty much closely mirrors the Enneking staging system of benign, of Arabic 1, 2, or 3. Pretty close. So these are going to be benign 1 or benign 2 lesions on the staging, because radiography look at that and say, well, that's just kind of sitting in the bone, not doing much. And indeed, in this case, the bone is walling it off, saying, okay, I don't like you there, but I'm going to stop you from going anywhere. A 1B lesion is geographic with a distinct border around it, the zone of transition, the radiologists call it, from where the lesion is to the rest of the bone, where the lesion is to the rest of the bone. This is growing more aggressively or rapidly, if you will, than the 1A lesion, but still not so bad that it's just the bones melting away before it. All right? So this is a benign active kind of thing, or potentially a benign aggressive sort of thing in the staging criteria. Who would like to venture to guess what this is? Giant cell tumor. You all said that's perfect. Excellent. This is a chondroblastoma. What I'm going to tell you later on, we'll look at chondroblastomas, but one of the things, the periacetabular region tends to be a chondroid type of area. It's a very common place to get chondrosarcs in an adult, or a chondroblastoma in an adult as well. Mets and chondroid-like things like to go in the periacetabular area. And the Lodwick type 1C is geographic with an indistinct border. So again, it logically concludes or extends that this is slightly more active histologically than the last, and that's the case. Here's a lesion here, here's a lesion here. There's another EG, this diaphyseal. This was actually a fibrous dysplasia that is not kind of well identified here from side to side. The type 2 is so-called moth-eaten, has no reactive rim, and is just sort of scattered through the bone, all these little spots everywhere. This is a more aggressive lesion and multiple. When you see these moth-eaten lesions, you're thinking something like Mets, lymphoma, or round cell lesion of some kind. And type 3 is permeative, cortical penetration and ill-defined so-called transition zone. We're not really sure where this starts or stops, but this looks abnormal through here, and you're worried about it. Again, that could be something as simple as infection or something as bad as a Ewing sarcoma. So again, Lodwick classification kind of helps you identify how aggressive the lesion is and what it's doing to the bone. And then just have to mention Pfemmister's law, which is one of these yeah, I know, but we don't think about with bone lesions. Pfemmister's law, bone lesions occur in the areas of greatest bony activity, which is why we see tumors in the proximal tibia, the distal femur, the proximal humerus, and so on and so forth. That's where you're going to see those bony lesions. That's where the osteosarcs, the giant cells, the chondroblastomas, the osteoblastomas, etc. That's where they're going to show up, and that's where you see them. So it sort of makes sense. All right, and this is a good pearl for you. My residents can all spat off the top of their head after about the day 2 of their PG2 year. The big 5 that can look like anything. If you get called up when you go back to look at a bone lesion, or you're a visiting professor next year at your alma mater or something, and somebody shows up, throws this up there and says, all right, Dr. Smith, we've got this bone lesion here. What is it? You can walk up, and if you don't have the faintest idea what it is, look at it very carefully and make some comment about, okay, it's a mature person, proximal femur. It looks like geographics, not well marginated. Lodwick 1C, blah, 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 blah. And everybody's going, oh, God, he's really smart. Then you can go, well, I think it could be metastatic carcinoma, cartilage lesion, fibrous stage infection, or EG. It's one of those 5. And most of the time, you're probably right, okay? Because these are kind of the 5 things that can look like anything. If you have no clue what it is, you can include that, and it will help you. I say this because, remember, these are kind of things that, first of all, will be on your boards, and second of all, can have a wide variety of appearance. So it's pretty uncommon if you see something on your board exam and you're not quite sure what it is. They're not going to list all these different things usually. they'll list one of these things so you can pick it and say, okay, well, I'm not sure, but this is one of those things that look like anything. I'm picking that. And you'll probably be right. Okay. Let's see. We'll go to this. So, we have taken a history. We've taken a radiograph. We're finishing our workup of this person that's come into us. We have to make sure that we get appropriate imaging studies. That will include a chest X-ray or a chest CT, particularly CT if it's suspected lesions. Now, it's important that you get the chest CT before the patient goes for a biopsy. And let me tell you why. Because when they go for the biopsy, unless you've done a needle or something and they haven't got anesthesia, if they go to sleep, what happens to the lungs when they go to sleep and wake up? Well, there's atelectasis, so you go, oh my gosh, my chief resident just told me that this is malignant, let's get a chest CT to work it up. And the report comes back, small areas at periphery, could be atelectasis, could be Mets, repeat CT in 6 weeks. And just go. So get it first. Get the chest CT first before they go for any general anesthetic to know what's going on. Also, make the hemonc guys happy because you can tell immediately, yeah, we've got this lesion and he's got blah, 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 blah on the chest. Whole body bone scans. We get the whole body bone scan to search for occult or multiple lesions, which of course will help you in your diagnosis, multiple myeloma, infection, and so on and so forth. And also to identify how hot the lesion is on bone scan. As we go through, you'll see that that's very helpful because a lesion that's sitting there and it looks kind of strange on X-ray, but if you get a bone scan and it's not hot, the bone scan really doesn't have much uptake at all, you can usually fairly confidently say, well, it's not a very active lesion, we can watch this. We don't have to do something aggressive to it. All right? But if it's blazing hot, you say, ooh, I'm worried about that. It's blazing hot and they're complaining and I can clearly see the lesion. We better work it up or biopsy it. So that's one thing the bone scan helps, of course, besides screening. The second thing you need to remember, and this does show up all the time, I know you've seen it on your in-service, is that if you think it's multiple myeloma, bone scan is not the screening test of choice, right? It is a skeletal survey. Because myelomas can be cold on bone scan. Here's a pearl to go along with it. Thyroid, metastatic thyroid, and metastatic renal can also be cold on bone scan. And they can be hot and or cold in the same person. You can have a person with metastatic renal that's hot in a bunch of places and have a big old lesion somewhere that's cold on bone scan. Don't know why, but that's a fact. So jot that down. That may save you some grief sometime in the future. And finally, of course, the MR scan, which is our test of choice for screening the bone, for looking for soft tissue, looking for Mets in the spine, skip lesions, so on and so forth. If you get an MRI of a bony lesion and you're worried that it might be an osteosarcoma, you must be certain that you see the whole bone. You got to. And it's a T1 image that is most helpful to you because anything that's displacing what's normally bright on T1, which is fat. What's bright on T1? Fat. I'm going to tell you 4 other things probably sometime later today. It's another thing you should be able to spout off what's bright on T1. But fat, the fatty marrow, if anything is displacing it at all, the signal there, then you got to know what that is. I'll show you some examples later on and we'll talk about that. CT scan of the lesion may or may not be helpful to you if you're looking at the specific architectures, a mineral architecture of a lesion. A CT scan is good because it has much better definition and tissue, what's the word I'm looking for, contrast, if you will, than MR for mineralization. It's very good to pick up subtle mineralizations or look at bony architecture. But most things we don't have to do that, and so we don't get typically a CT scan. But you can see here, on this thing, there's a big soft tissue mass out here with density through here and density in here. So if I was looking at that, I would immediately say, well, that could be either bone or calcification, right? Not sure which. If it was bone, what would the diagnosis be in here? It looks like a femur. What would it be? Osteosarcoma, you should be telling yourself. If it was calcification and not bone, what would the diagnosis be? Probably a chondrosarc, right? Because the chondroid tissue mineralizes. Okay. I'm going to show you all that, so pretty soon you'll know all that. Angiography, there's very little role today. I put this in here only to recognize, to mention to you that if you think you have a renal cell lesion, if you've worked a person up and you're going to biopsy something that might be a renal cell, you, by golly, better embolize it before you put something in it. Let me tell you a true story. I'm about 2 years into my practice after my fellowship of a partner who's now at the Mayo Clinic, a good friend of mine, very good surgeon. I get the stat page. Ted, come and help me in OR. I don't remember what it was, one of the smaller ORs, 12 or something. Now! It's like, okay, all right. I run in there, there's blood dripping off the lights. There's like 18 anesthesiologists in there squeezing bags. That's bad when the anesthesiologists outnumber the surgeons by like 10 to 1. And he had biopsied this little tiny rib thing that was a renal cell. So if you don't think those bad boys will bleed, do yourself a favor, embolize it in advance if you think that's the case. Because this guy nearly died from a little tiny incision in a rib lesion that just absolutely couldn't control. Embolize what you suspect to be a renal cell in advance. That means you've imaged their gut to make sure there's no mass there and check renal function, so on and so forth. Okay? And finally, in your workup, what other studies? Well, if you're not sure what it is, if it hasn't shown up on the chest and hasn't shown up on bone scan, the last thing you do is run the scanner in your course through the chest and down through the abdomen and pelvis. Mike Simon put a study out in the late 80s, multi-center study, that basically said 85% of occult lesions are picked up by scanning through the chest, abdomen, pelvis. If you don't see something there, you're probably not going to find it. Okay? You're probably not going to find what the source of the lesion is. So here's the picture of a CT scan. See how nice this mineralization shows up. This is synovial sarcoma. And we'll talk about that why later when we talk about those. And of course, angiography, tumor blush. When you're going to embolize something, how long do you have before you need to operate on it before that embolization is no good? I don't know, Parsons, you tell me. Come on, you guys know that. 24 hours, really. So you need to tell those guys, hello, I'm operating on Monday at 7 o'clock. So get your booty out of bed. You're talking to the specials guys now. And get to the hospital on Sunday and embolize it so I can do this. Because they'll tell you, no. We'll do it Friday and you can operate on it Monday. No, it doesn't work. Tell them they get paid just like you do for working. They got to go on Sunday. So you have 24 hours usually, because after that it starts to recanalize the vessels and all, and it hasn't done you any good. So 24 hours or under. Okay, and finally, what lab studies do you need? Well, labs are nonspecific in working up the tumors, but they may help in some unknown lesions. A young person under 30 years of age, CBC sed rate, peripheral blood smear will probably help. Older patient, although I have to say that I say over 40, I'm well over 40, I don't consider myself that old anymore, but CBC sed rate, peripheral blood smear, SPEP, UPEP, the electrophoresis, urinalysis, prostate, specific antigen, and serum chemistries. Give you sort of an idea of what's going on in general to work up the lesion. Okay, and finally, you're ready to do the biopsy. Now this is where I get in my soapbox for a little bit. Don't you do the biopsy unless you're going to take care of the patient. There's nothing that ticks off an oncologist more than to have somebody come with a biopsy that was incorrectly done, all right, with maybe a diagnosis that might or might not be right, as you'll see in a minute here, and they say, well, I did this, I worked it up for you, and now you take care of it. Let me tell you that there will be enormous pressure on you when you're out in practice next year by your partners, by your hospital, by your HMO, or whatever it is, to not lose patients until you've milked all the money that the system can get from you out of that patient, okay? Which would include working it up, the imaging studies, the biopsy, and everything else. I don't care if you work it up, just don't do the biopsy unless you've already talked with an oncologist, because there's problems associated with it. All the imaging has to be done, and it has to be small, well-placed, longitudinal, that doesn't contaminate surrounding structures. And you'd be surprised what people will do to say, well, I just did a little biopsy, transverse incisions, or they come to see you and there's a hematoma all the way down to the foot, or whatever. It really, really makes you irritated. Okay? That's enough. I'll get off my soapbox now. You get my drift. All right. So the biopsy has to be located at a place where it can be excised at the definitive resection. All right? And careful hemostasis. Whatever, if this is a malignant lesion, they have a big hematoma all the way down the leg, you've just contaminated the entire leg. Well, we're going to cut their leg off? Well, that becomes a discussion you have to have with the patient. It's not a very pleasant discussion. You get frozen section at the time to make sure you have adequate tissue. This is something that if you're biopsying something you're pretty sure is benign and you feel comfortable, you talk with the oncologist and say, yeah, go ahead, I'm pretty comfortable with that. Get a frozen section. The pathologist will say, well, excuse me, doctor, is this going to change your opinion and what you do in the operating room? And your answer is, yes! Go to the lab and read the stinking thing. Or take it down yourself and read it with them. If you've got somebody you can leave in the OR. Why? Because you want to know if you have lesional tissue. If you go and you take a little capsule around this, and all you guys inflammatory capsule, and you say, oh, I did it small, I did what Parsons said, longitudinal, well-placed, small incision, didn't contaminate stuff, and the pathologist comes back and says, hey, this is nice. This is inflammation, reactive inflammation. Well, is it inflammation because it's an inflammatory lesion, or because you got the capsule? All right? So do a frozen section, make sure you have adequate tissue. That's the reason, and the answer is yes. Besides, they're supposed to be doing, the pathologists play too much golf anyway. They need to be in there doing that stuff. Get cultures. You know, the Ennekingism is culture all tumors, culture all tumors and biopsy all infections. You got to do both. Make sure that you've done both, because round cell lesion looks like pus, and it may be a round cell lesion, and pus looks like a round cell lesion, vice versa. And finally, don't give antibiotics until after the cultures are done. Now, what's wrong with this picture? This is an old Netter picture. Here's the tumor here, probably trying to show us an osteosarcoma, and the incision right there. What's wrong with this picture? Well, if that's a small incision, then all you need for an incision is from here to here. You don't have to expose this whole big thing of tumor and then take a little tiny piece out of it. Goodness sakes, if I was going to expose it like this for a biopsy, I'd give them this whole big thing here to look at so they could make sure they got the diagnosis right. All right. So Henry Mencken wrote this paper, it's, goodness sakes, 9 years ago now, although it's the most recent of the series, that talks about the difficulty of biopsies being done elsewhere. But notice that errors in diagnosis, complications of biopsy, changes in course of treatment were 2 to 12 times greater if the biopsy was performed at the referring institution, and more than a quarter of those biopsies were the wrong diagnosis. And finally, the greatest risk is to the patients when malignancy is not considered in the preoperative diagnosis. That's one of the greatest risks of recurrence, is if someone gets operated on and the surgeon didn't think it might be malignant, and they do some muck-around operation, that person is really been compromised. Potentially their health has been compromised. So, don't you do it unless you're going to take care of them. All right, what types of biopsies are there? This is the kind of stuff that you will have to potentially know. Fine needle aspirate, core needle, and open biopsies. Fine needle aspirate is good for cytolytic evaluation and requires experienced pathologists, but here's the rub. It's only about 70 to 75% accurate, so a quarter of the time you may not really know. So can you do this in institution and get an idea? Sure, that's fine. If it doesn't come back, diagnostic, then you can move on to the next thing. A core needle biopsy is less invasive, less contamination. We worry about sampling area. Well, everybody knows the sampling area would be if you got a certain part of the tumor that happens to be benign or less aggressive in appearance, the pathologist may undercall the lesion. Core needle biopsies are about 85% accurate, which is much better. Open biopsies, which are still the gold standard, are 96 to 98% accurate. Most of the time we do an incisional biopsy. Small, well-placed, take a piece of tissue, take some cultures, close it up, stop, and wait for the final answer. When I go to do a biopsy, I tell my patients, this is what's going to happen. We're going to go to the operating room, we're going to make an incision. If the pathologist says, yes, it's benign, and it looks like something that I was thinking about in the differential, we'll proceed. If he says, I don't know what it is, we'll stop. If he says, it's malignant, I still stop, because I want him to prove to me that it's malignant on final pathology, and if he doesn't know what it is, I want to make sure it's malignant before we proceed to do whatever. So 2 of the 3 choices, you stop and you come back another day and take care of the patient. The worst thing you can do is review a case of a person who had a hemipelvectomy for something that was thought to be an osteosarcoma at frozen section. It turned out to be an osteoblastoma or whatever. Okay, that's bad. Excisional biopsies are something that you can do, but very rarely. And the only thing I'll say about excisional biopsies is, if you can take something out, it's so small and so superficial that you can take it out such that it's completely out without having contaminated a bunch of tissue, and the pathologist comes back and says, oh, guess what, that was an MFH. You can say, no problem, my margins were clear, it's fine, I didn't do anything more morbid than I had to. Then that's in the case where you do an excisional biopsy. That's pretty rare. By and large, you should do an incisional biopsy because you don't want to contaminate a bunch of tissue. And then finally, frozen section we talked about, make sure you have lesional tissue. The problem with cartilage and fat lesions is what? Well, with cartilage lesions, they cut pretty well, but they're sampling error. Chondrosarcs may have areas that look very bland and areas that look very bad. We'll talk about when we talk about chondroid lesions. Fat, what's the problem with fat lesions? It doesn't cut on the microtome. You put it in there, you freeze it, you cut like this, you get a hole. And they say, well, sorry, we can't tell you. So if you're going to biopsy a fatty lesion, typically you can't do a frozen section. So here's an example of giant cell tumor, MET, or a chondrosarc. Okay, these look pretty different. You wouldn't confuse those to look at them. And if you had a small core needle biopsy or something, you could tell the difference between those if that happened to be your differential diagnosis. But in this case, you have eosinophilic granuloma, a small round cell lesion, or myeloma, a small round cell lesion. And if you give the pathologist a crumb of tissue or a few cells, he'll say, oh, it's a small round cell lesion. Well, if that was your differential diagnosis to begin with, that's not helpful. So you need to be able to get adequate tissue for diagnostic sake. All right, so the histology of the lesion. This is how the pathologist assign a grade to the tumor itself to decide whether it's good or bad. Overall cellularity, nuclear cytoplasmic ratio. If it's very cellular, if there's a lot of nuclear material as opposed to cytoplasmic, if there's atypia, in other words, the cells don't look like it normally would for that type of tissue cell. It doesn't look like an adipocyte. It doesn't look like a muscle cell. And pleomorphism, this is what Dempsey Springfield calls a Star Wars bar. None of the two cells look alike. They all look different. Okay, that's the pleomorphism. And then finally, presence or absence of necrosis. These are the things that you're expected to know that would help make the diagnosis of a high or low-grade lesion based upon the histology. All right? Here's an example of an MFH. Who would like to venture to guess what this is? Has a sort of herringbone pattern to it. I just gave it away. Fibrosarcoma, right? Interestingly, they don't look very aggressive. And here's an example of chondrosarc. All right, so now we're to the treatment of these things. You want to remove the lesion with minimal risk of local recurrence. That is the goal. Limb salvage is today's standard. So by and large, if you're presented with a question of a malignant lesion that needs resection, your answer is typically going to be limb salvage for a high-grade, stage 2B lesion. Local control with a limb salvage should be close to amputation. Amputation rates, believe it or not, have about a 1 to 3% recurrence. It's probably because the amputation was done too close, or it was a very aggressive lesion that wasn't identified at the time. About an 8% or less for limb salvage. But again, limb salvage is the gold standard. That's what you pick for surgical treatment. You want to also make sure that it's functional. It has to be functional compared to amputation. If the person has a limb that you save, but it's dysvascular or only partially vascularized, and it's insensate, and they can throw it over their shoulder and drag it along with them, okay, that's not doing them any good. They're better off with a prosthesis that they can actually walk on. In general, if something can remain innervated and it's not very well vascularized, it's okay, or vice versa. If it's vascularized and it's not innervated, it's probably okay, but you can't have both. Start losing sensation, you start losing good vascular supply, you're better off with an amputation. Local recurrence for these lesions may be associated with the presence of MET. This is controversial. I don't think that's going to show up on your boards, but this seems like a no-brainer, but is probably something that you might see. Local recurrence is associated with a worse prognosis. And that's probably because it's a high-grade lesion, which means it's got a worse prognosis anyway. Here's some of the risk factors for local recurrence. Positive margins, that begs the question. Didn't get it out all the way. Persistent disease in the tumor bed, excision following an unplanned excision. That's what we were just talking about. Don't muck around it if you don't know what it is, or if you're not going to take care of that malignancy. And finally, some lesions, fibrosarcoma and malignant peripheral nerve sheath tumors, have a higher risk of recurrence just by virtue of the behavior of the tumor. We'll talk about those when we go to those specifically. And of course, wide resections. That's one thing about tumor surgery. It's not hand surgery. You don't make a little tiny incision. You make a big incision, big exposure, a lot of anatomy, and soft tissue around the tumor. And then we reconstruct them these days. Oops. Here's the biopsy site. Remember, you have to excise the biopsy site with the lesion. Exposure with the soft tissue intact around the tumor. And then you end up with this kind of deficit. There's the patella. Here's the proximal tibia. Here's the femur. And then you can reconstruct it with a prosthetic reconstruction, with a composite osteoarticular allograft, or with a composite reconstruction of allograft and hardware. There are different kinds of procedures you can do. This is an anakingism again. What do you do? An intralesional resection is through the tumor. You don't want to do that unless it's a benign lesion that you're just scraping out. Then it's okay. A marginal resection is through the reactive zone of the tumor. A wide resection, which is the standard, here you go, for limb salvage, en bloc, in other words, total removal with a cuff of normal tissue. A radical resection is remove the entire compartment, which we don't really do anymore, except perhaps if there's not going to be any adjuvant treatment. Those are the choices for surgical procedure. This is typically what you select: wide resection, normal tissue around it. Surgery has to be individualized to each patient, but remember, your first chance at surgery is your best chance to get control of the tumor. And here's just another cartoon showing the different resections. This I put in here mostly to show that even if you do something as radical, and amputation potentially as radical as an amputation, if you amputate through the lesion or through the reactive zone of the lesion, that's a bad thing. It's very bad if you do an amputation and convince the family that we're going to do this because the tumor's too big, we can't save the limb, and then you try in an effort to give much more length to their above-the-knee prosthesis or whatever. If you go too close to the tumor to get a recurrence. That is very bad. Their lawyer likes that. Your lawyer does not. Neither do you. So if you're going to do an amputation, make sure that you are well away from the lesion. All right, now down to some of the nuts and bolts. This is more boring stuff, but some of the things you have to know, and then we'll go on to the specific tumors, which is you're all dying to know. I can tell. I can see all the excitement in the room. It's killing me. Chemotherapy. Chemotherapy is the reason patients survive malignant bone tumors, okay? That may be a question that you'll see. You've got to recognize that it's chemotherapy and not the surgery that's important. It's given preoperatively, so-called neoadjuvant, and postoperatively, so-called adjuvant, and usually for several months. 5-year survival rates are 60 to 70%. For osteosarcus, right on 65, 70%, for example, versus about 10% in non-chemo patients. So in the past, when we didn't have multi-agent chemotherapy, everybody died. Well, 9% of them died. Now, most people live, but it's because of the chemotherapy. For soft tissue lesions, they're gaining popularity. It's still somewhat controversial, but more and more the hemonc guys are saying, yeah, let's give them chemotherapy for these soft tissue lesions. So here's something you got to remember. Don't get confused. If you see a bone malignancy on your board, the treatment is going to be chemotherapy, resection, typically limb salvage, with a wide resection, and more chemotherapy. So bone lesions, chemo, surgery, chemo. For soft tissue lesions, the black dot answer on your board is still resection and adjuvant treatment, typically with radiation. So surgery and radiation, typically for the soft tissue sarcomas. There are a few exceptions to that, but in general, that's what you need to remember. So chemo and surgery is the standard in bone sarcomas. Here's a list of some of the chemo agents we use, which you don't need to memorize, but I put these couple things in here to remember that if they get doxorubicin, you got to remember cardiac toxicity, so you have to get a MUGA scan or an echo before you operate on them. Or if they've had bleomycin, you got to check out their lungs because they can have some problems associated with the chemo. Chemotherapy is amazing stuff. It kills cells, and so people, they get bald, they start to slough their gut, they bleed at their gums, we suppress their marrow. We say, it's absolutely safe, it's okay. Well, it's not absolutely safe, but you got to do it for the tumor. So it does have some side effects. And the older the person, the less well they'll tolerate chemotherapy. An older person may, 60, 65, 70 years old, we may not be able to give them chemotherapy because they just won't survive the chemotherapy. The morbidity is too high. So remember, chemotherapy is the reason they survive, but there are some side effects. There are 3 classes of biologic agents: those that damage DNA, those that deplete the building blocks, or those that interfere with microtubule function. That's probably not so important to know, although recognizing it as this. In years past, we always taught that, well, there's rapidly dividing cells, they can't repair the chemo damage. This is probably what is really going on: programmed cell death or apoptosis, loss of normal controls because of the chemotherapy. So that question may come up. How does the chemotherapy work? It's because you've destroyed the normal cellular control and it's programmed cell death. And remember, it's G1 through S phase where it's most sensitive. That's where DNA synthesis takes place. So that's obvious. Okay, radiation therapy. Radiation therapy is measured in grays. Probably all of you know that. Occasionally you hear some guy saying, well, he got 1,000 rads, this or that. Don't say that to the radiation oncologist. They think that you're a dork if you talk like that. You got to talk their language, grays. So 1,000 grays is 10 centigrade. 1,000 rads is 10 gray. What happens here is you get free radicals are released. You get oxygenation of water, release the free radicals, and that causes DNA injury. Now, we don't line people up and one time give them a mega dose with the guy holding the button down for 90 seconds. You do this in fractionations. The reason is listed there. You avoid exceeding the tolerance of the tissue around it. In other words, you don't burn up everything around it by giving it to it a little bit at a time. You minimize the risk of late complications. Fewer, larger radiation doses are more likely to have wound complications as compared to the smaller, multiple fractionated doses. This is very important. The cells become in phase and more sensitive to radiotherapy. Since the cells are cycling through this reproductive cycle, as you hit them each point as they're going through DNA, they pretty much line up because they're dead through the DNA phase or cycle. So they line up, and hence they're more receptive or more sensitive to the radiation. And typically we give, notice 5 days a week, the the radiation oncologists don't work Saturdays and Sundays. It's great. Typically we give about 180 to 200 centigrade a day, which means they get about 10 gray a week. All right? Roughly 10 gray a week. So here's some typical doses for treatment of tumors. Most Mets get somewhere between 25 and 30 gray. So 2 to 3 weeks of radiation treatment. Soft tissue sarcomas get between 45 and 60 gray. Bone sarcomas, we really zap them. They go 60 plus. Positive margins, you see 45 to 60, and benign aggressive lesions at 40 to 50 gray. This is something good to keep in your back and your mind. More importantly, for your own well-being and practice, you got to remember these numbers here. If you give somebody 45 gray or less, you're going to expect healing. And if it was recent, prior to surgery, you got to give them a couple weeks off for the radiation before you operate on them, because the wounds will be all inflamed and they fall apart. And there's almost always delayed healing after preoperative radiation. As a matter of fact, the complication rate's about 20%. It's pretty high. Sometimes you still do it, but it's pretty high. If they get between 45 and 55 gray, you'll expect delayed healing and wound complications, but they probably will still heal. If the person's had 60 gray, they're severely compromised and the wounds may not heal. Let me give you an example. A few years ago, I had a person come into me that fell in Austin walking across the street. She had this big intertroch fracture. The guy that saw her in the practice said, "Oh, I know what to do in intertroch fracture. Fracture, nail." Well, he forgot to ask why, the history and all this. She had had some radiation, 65 gray for a bone lesion for an osteosarcoma in the area that was treated a number of years ago with whole earth radiation. So she had 65 gray. So he made a big incision on her booty and slammed this nail down in there and sent her to see me. Well, it never healed. The incision never healed. The bone never healed. This thing's wobbling all around her all this time. I said, hyperbaric oxygen, all the stuff didn't heal. Finally, we ended up resecting all that stuff and putting a big flap across there and left her with an unstable leg because she refused an amputation. But recognize that people that get radiation doses may not heal. So that's going to help you in your practice. Okay, external beam radiation we use for local control of round cell lesions like Ewing's, myeloma, lymphoma, and Mets. We used frequently for adjuvant treatment in soft tissue sarcomas. It improves local control rates. It may be used with chemotherapy and Ewing's, but most of us favor chemotherapy and surgery. So this is American Academy of Orthopaedic Surgeons. So on your boards, if you're given how do you treat that Ewing's, it's chemo and surgery, not chemo and radiation. All right? We'll talk about that when we go to Ewing's. But remember, in general, we like to do surgery and chemo. And remember that there's also a risk of post-radiation sarcoma. About 5% of these people will develop a secondary sarcoma because of the radiation. It's not a benign thing, and it's a very high-grade lesion, very poor prognosis. All right, last thing, and then we'll go on to the bone lesions in particular. These are some of the things you need to know, but in particular I'll point out what I think you have to know, and it's simplistic things about suppressor genes and oncogenes. Molecular biology, of course, is a big deal, a lot of interest in that. Tumors are clones of cells that are become aberrant, and their cellular growth control is, of course, off. We think it's DNA damage and the local controls that don't function. To become neoplastic, two things have to happen. DNA transcription, translation, replication is inappropriately turned on, and then the control is lost. All right? So, well, how do these things happen? Well, chromosomal translocations is a big one. Up to 95% in some sarcomas, in particular Ewing's, it allows expressions of genes, the oncogenes particularly, that are usually not active. So these are some of the more common ones. You have to know for your board that Ewing's is an 1122 translocation. You just got to know it because it'll probably be asked or mentioned. Another one that's becoming more and more common to talk about is chondrosarc, this 922 translocation over here. All right? And this is what happens. Here's the 922 for chondrosarc, for example, and this area over here gets broken off and attached over here to the 9, and the 22 is short. So then it expresses an oncogene, which wouldn't normally be expressed. Okay, that's translocation. Just recognize that that happens, and that's one way these genes are expressed. So we'll talk about suppressor genes and oncogenes. Suppressor genes are the good guys. These inhibit cell proliferation. Growth suppression involves mutations in genes that inhibit cell proliferation. So there's two of them that have been studied pretty extensively, and one of these two, if they ask you about a suppressor gene, is going to show up. That's the retinoblastoma gene, which acts as a regulator of gene expression, and the other is P53, which prevents entrance into the S phase of the cell cycle. So when you lose that, you lose control, and it's pretty common in osteosarcoma and chondrosarcomas. So the RB gene is a recessive suppressor. Both of them have to be affected. It's present in all retinoblastomas, but there are other things that show up. 35% of all osteosarcomas have retinoblastoma gene mutation, and retinoblastoma people also get other tumors. So again, it's a sort of this overall problem of the suppressor gene. The abnormal state, which is the phosphorylated state, prevents DNA binding, and you get ungoverned proliferation. What do you need to remember? Retinoblastoma is a suppressor gene. When it is in its phosphorylated state that is abnormal, there's no suppression, there's no control. The cells go wild. Remember that. Essentially the same thing for the P53. Is mutated in about 50% of all tumors. It's a dominant suppressor, so you only have to have one bad copy as opposed to retinoblastoma. All right? This arrests the cell cycle when the DNA is damaged. So if you don't have P53, that damaged DNA gets passed on, and you get these mutations. And hence, why you see about 20 to 65% of osteosarcs have P53 mutations. This is just a cartoon, shows that the cell cycle arresters can work in different areas of the cycle, the cell cycle, to help stop proliferation of bad cells. So here's the oncogenes. These are the bad guys. These are genes that are involved in cell growth, but are abnormal or hyperfunctional. They're usually not suppressed. So when these they're usually not expressed, excuse me. So when these are expressed, and they're normally not, they induce uncontrolled growth. Whereas the suppressor genes prevent it from happening, these force it to happen, and hence they're the bad guys. So there's a bunch of them are described. I put a couple of them here. I don't think anybody's going to ask you what is the oncogene expressed. You just have to understand the concept that when an oncogene is expressed, it means it's causing uncontrolled growth. And there's just Mendelian stuff. Recessive oncogene. If you're genotypically abnormal, but your phenotype is normal, you're okay if it's a recessive gene. But if you have another mutation, here you go, that's a neoplastic cell. A dominant oncogene, one hit gives you a neoplastic cell. And same thing, recessive, additional mutation gives you a neoplastic cell. That's pretty straightforward. So the transformation to malignancy is usually the result of interplay between suppressor genes and oncogenes. That's the bottom line. The contribution of each is not clear, but understanding that one or the other, what they do, is what's going to be expected for you on your test. And finally, METs. Metastatic lesions, cells become metastatic if they can escape this primary site, travel to a distant site, and set up shop. If they can have a picnic somewhere else and get there. But notice this is very uncommon. Less than 1 in 10,000 cells is able to do so. Why? Because it has to do all these steps. It has to break down the tissue to move, so it's got a diapedese somewhere, move through the tissue, get into a vessel, survive the roller coaster ride through the vessel to a distant site, evading the immune system, or the popo, as my kids would say, lodge in the distal site, and then get a fibrin clot around it to protect it from the immune system. It has to exit the capillary, walk through the tissue, get a blood supply, and then divide. So that's a lot that that cell has to do in order to get somewhere else, which is why that its metastases are relatively not that common, so to speak. 8 successful steps. Oh, and I will say, one of the questions that seems to come up pretty frequently, I know you've seen it on your in-service, is when you get bone destruction from a met, why does that take place? Is it because the metastatic cells are in there digging away at the bone or whatever? No. Bone knows one trick, make bone. Well, bone's only destroyed one way, and that's how? Osteoclasts, right. So bony lesions, metastatic lesions are the result of osteoclastic activity, all right? Osteoclastic activity. Normal osteoclasts are stimulated by the presence of these neoplastic cells that release osteoclastic activation factor, OAF. Okay. That's enough for the introduction. It's probably all more than you wanted to see. You need to stand up and stretch for a second. Don't leave, because we've got too much to go through, but just stand up and stretch for a second, and we'll start on the meat of these talks. If you have any questions, now's a good time to ask. Oh, everybody's leaving. That was a mistake. Bad call, Ted. Yes?
Suppressive gene, you need to knock out both of them for it to...
If it's recessive. If it's a dominant gene, only one has to go bad. If it's recessive, both have to go bad. Correct. Correct.
The same thing with retinoblastoma?
A retinoblastoma, both of them have to be out because it's a recessive gene. That's exactly right.
How long can a sarcoma sit around before it metastasizes?
Ooh, that's a good question. Nobody knows. Depends upon the grade of the tumor. Sometimes they, a very short period of time, probably days or weeks. Most of the, if it's a low-grade malignancy, yes.
Like liposarcoma?
Liposarcoma could be if it's a lower intermediate grade. The ones that classically show up 10 or 15 years later are synovial cells or maybe chordomas, for example. It could show up very, very late. I'll mention that as we go through that, because some of them show up late, but that can be there for a while.
Which activators do you think would be on the test? Rank L?
I don't think they're going to ask about any specific activator. I honestly don't. I've never had a person come back to me and said, golly, you said that, and that showed up, but they asked me about it. No, I don't think that's going to be a problem. Just understanding the concept right now, because the rest of it's too controversial in terms of what's specifically been identified.
Recommended biopsy site proximal humeral lesions, delta pectoral, or
Just lateral to delta pectoral. If you go medial and it contaminates the chest wall, it's a problem. Go just lateral, then you can still make your approach and excise that out, but you haven't contaminated the chest wall. Yeah, after 2 weeks.
Well, this lady, this example you gave, how many, she said she had years of radiation.
Oh, I'm talking about preoperative radiation. For 60 grade? No. They've got 60 grade, you're hosed. I've had numerous patients come back and they say it's 65 grade and I've got this thing here, can you do it? I said, no, I'm not operating on it. Or you'll see somebody come from the dermatologist, he scraped it off. He said, I got this sore here, it's never healed. It's because they got 60 grade and it's never going to heal. The osteoclasts seem to have receptors for the neoplastic-induced OAF. So they do. So it varies from tumor to tumor, some more so than others, like lung and breast and all that go to bone very easily, as opposed to some others. But yeah, they do. They seem to be receptive. Okay, let's get started again. If you'll have a seat. Now I got through all the boring stuff. Hopefully everybody's still with me. They haven't got the deer in the headlight look. As everybody's getting a seat, I started doing these things in chapters. If you're saying, well, what's the deal with this? How come he doesn't just have one big long presentation? Well, the first time I did this, Mark, who started this course, I guess this is the 10th year. This is my 7th year, I guess, speaking here. We did slides, and then Mark finally just said, we're not going to do any more slides. It's just as well, because I came here one day, and I traveled here with 2,200 slides. So I'm carrying all these things, and they weren't loaded already. There's no way I could have done that. The airlines would have laughed at me and told me to go home. But I got them all loaded up upstairs when this was back when it was in Colorado Springs. I walk down here. I'm carrying these things, very carefully. You've all carried slides around, and you think, oh my gosh, if I drop this, I'm hosed. Well, that's exactly right. I'm walking down the aisle. One of the residents stood up, bumped me. The one on the top went, it landed on its side, flipped up in the air, it's gyrating like this. Of course, it's all happening in slow motion in my mind. I'm thinking, no! And it's spinning around. It didn't break open. I'm thinking, yes, it's going to make it. It hit again and bounced. It didn't break open. It hit the third time. Kapoosh! So there were slides all over the place. And I was in tears, sobbing on the ground. And then there's, the typical guy that you think of, the nerdy guy with the glasses and the pocket protector and a little bit on the dumpy side. He's sitting right there. He's saying, oh, what happened? Gets up and steps right in the middle of it and slides all crack. And it was miserable. So then I go and say, that's it. I'm done with slides. We're not doing this. Miller, of course, Mark had to say, well, changing program. We're going to do this. We'll do his talk later today and so on and so forth. So I go back the next year and say, okay, I'm putting them all on a computer. I went home and I started just putting all the stuff in. Type, this, that, go, 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 go. One day the computer wouldn't open. I had no idea that there's a limited amount of information you can put in one PowerPoint talk. So I got all the stuff in there, and this is like 3 weeks before they're due to come to mail down there. So finally I took my neighbor, who actually has a computer business, to take it down to the the television station supercomputer to crack it open and divide it up into bits and pieces. So for your future reference, if you're going to do a PowerPoint talk, you better keep it under about 250 to 200 kilobytes or whatever it is it does. I don't know what it is. When it shows there in the number there, if you get 125,000 or whatever, don't go much after that because it may not open and you may be sorry. And that was a very difficult time. It was a stressful time for me. Okay, bone tumors. We're going to go over, we couldn't possibly go over all bone tumors. The stuff I showed you this morning is to help you understand as we talk through this, and of course as you take your test, think through the questions that are asked. I will show you the stuff of the things you're likely to see, try to answer your questions, and make it pretty clear to you. Textbooks and textbooks are written about this stuff, and what you want to know, I understand, is just tell me what's on the test. Just get me to pass the test. Okay, I promise, I'll do that. So we're going to talk about bone-producing lesions first. And these are essentially three for test-taking purposes, although I'm going to show you a list of them later on. Osteoid osteoblastoma, and osteosarc. You will see an osteoid osteoma, and I guarantee you see a couple of questions on osteosarcoma. You may or may not see an osteoblastoma. So osteoid osteoma is one that everybody feels comfortable with. It's one of these questions that yes, and you move on because you recognize it. These are young patients, a 2-to-1 male-to-female ratio. 50% are in the long bones of the lower extremities. They're typically in the metaphysis or the diaphysis. And these people have pain. It increases with time. It's commonly felt at night, relieved by NSAIDs. We think because it's prostaglandins or prostacyclines in it. And it can be referred to the joint, if it's nearby a joint, simulating arthritic-type symptoms. And classically, they say that alcohol may exacerbate the symptoms. I see very few patients where actually that's the case, but that's one of the classic textbook things. In the spine, if they show up in the posterior elements, typically it can give painful scoliosis or even growth disturbances. Typically what you see radiographically is the reactive bone. Remember, so this is something that's ticked the bone off, that the bone's forming around it, all right, around this radiolucent nidus. The nidus doesn't always show up. If it's in the medullary cavity or in the metaphyseal bone near a joint, it may be difficult to see. So sometimes you have to get a CT or an MRI, although CT is best to detect the nidus. Here's an example on a CT scan. And the sclerosis can be very, very intense around these lesions, except around the joints. We're not exactly sure why, whether it has to be temperature or what, but sclerosis around the joints and in the intramedullary cavity is not that great. The nidus is small, less than 1 to 1.5 centimeters. If it's larger than that, if it's larger than 2 to 3 centimeters, then it's going to be an osteoblastoma, right? Which is histologically the same. I'll show you that in a second. But lucent or rarely sclerotic nidus, I've only seen that a couple times, not to worry about that. And then you may get extensive sclerosis around it. So here's an example in the cortical bone that you see on cross-sectional imaging. It's always hot on bone scan. and here is radiolucent nidus, okay? These may spontaneously resolve in 5 to 7 years, and you can do that if you can convince the person that they should put up with this pain, because they usually get you around the throat and say, take it out now! And then, okay, that's fine. Most people don't want to put up with it. And if you can give them the anti-inflammatories. Most of these people will say, yeah, I take Motrin, it gets better. Yeah, I take aspirin, it gets better. These can be misdiagnosed as stress fractures, and you can see why, because it gets the bone formation and something's irritating the bone, and the bone knows one trick. Oh, this is a good time for me to mention, why is a bone scan hot? You know, there's not some technician just dropping black ink on the thing before he hands it to you or whatever. Why is a bone scan hot? Bone scans show two things, right? Shows osteoblastic activity, okay? And what's the other thing that will make a bone scan hot? Flow, blood flow, all right? Because the tracer's in the blood. So whether you get a static or pooled phase or an active phase, you know, 3-phase bone scan, you're going to see blood flow activity or you're going to see osteoblastic activity. Just remember that. Physiologically, you need to think about that when you see if somebody has a hot bone scan. It's hot because the osteoblasts are revved up. Well, osteoblasts are revved up for many different reasons. It may be revved up because there's increased turnover, like in Paget's disease. It may be revved up because you've immobilized them and put them in a cast, right? And so you get bone resorption, and coupled with bone resorption is bone formation. They're coupled together. If they're not coupled, then we all turn into Pagetic beasts. All right? So bone scans are hot because of osteoblast activity or flow. Just remember that. It will help you kind of sort out what you're seeing and what's going on. So here's the classic example. You see something's going on here. The cortex is widened, and you see the nidus better in the lateral. And on CT, it shows up great. Now, I love this case. It's several years old. I treated this guy several years ago, but I love it because little brother over here, the fibula's got growing pains with Big Daddy. Like, oh, I feel so bad for you. He's got bone over here. It's amazing inflammation from these lesions that form. This is all abnormal reactive bone, but notice here on the radiograph, you can tell that this is something that's been going on for a while and not real aggressive because you've got this nice smooth bone that's formed as opposed to onion skinning or hair on end appearance in the periosteum. This is something that's been going on for a while. Here's one in the proximal femur, hot on bone scan. MR shows the bright nidus, although MR is not as great for doing this as a CT scan. And here's the radio lucent nidus on CT scan. Remember, MRs show you signal intensity, and the CTs and radiographs show you tissue density. Density, all right? Don't confuse the two. Here's another example in the tibia, common location, hot on bone scan. And here's, you can see the signal on a T1 image and a T2 image of the MR. Here's one around the knee, very difficult to see, but you can see it on this MRI rather. You can see the nidus in the MR scan. You get just a little bit of reactive sclerosis in the metaphyseal bone. So other imaging studies are helpful. So how do you treat these things? Well, you have to remove the nidus, either by radiofrequency ablation to fry it or to take it out surgically. It's only the nidus that's abnormal. All that reactive bone does not need to come out. So here's a case actually here of a burr down technique. There's the cherry red nidus. You scrape it out with your curettes, and then you take the burr and widen that, so you do an extended intralesional procedure on it to get a bed like this. And they're pretty happy. Histology shows a distinct demarcation between the nidus over here and the reactive bone, which is over here. Within the nidus, you have woven bone, osteoblastic rimming, and variable degrees of mineralization within it. I'll show you a bigger picture in just a second. Remember, these histopath slides are on your review disc, so don't freak out. If you want to go back and look at them, you can put them on your computer and leave it on all night long to stare at it if you want to. All right? What's the treatment? Remove the nidus. I mentioned that. Radiofrequency ablation is much more common these days, or if you can nurse them along with anti-inflammatories, do so. But you know, these are kind of fun to operate on, so I don't know too many people that do that. So RF ablation, you put these people to sleep, you get them on the CT scanner, you drill down to this thing, you put the probe in, you heat it up 90 degrees centigrade for 6 minutes, The problem is it's about a 10 or 15% recurrence rate. And you have to do this under conscious sedation or something because these guys don't like these probes in there unless you can make them comfortable. Here's an example of one that failed RF ablation. Look at all this reactive bone that's formed. Again, nice and smooth. There's nothing about this bone that makes you think it's an aggressive process. All right? There's the nidus. This failed, so you can see it on MR. So we went and did a burr down, looking in this big thing for a needle in a haystack, finally identified it after we opened up this large area of sclerotic bone, and there it was. We scraped it out, and the patient did fine. So here's a larger photo, Mike. Regular shaped nuclei, okay, osteoblast with abundant cytoplasm, loose vascular tissue, prominent surrounding reactive bone. So here's a reactive bone, all right, and here's our cells, and here's this woven bone inside. Osteoid osteoma. All right, that one's an easy one. Osteoblastoma is the big brother. Same nidus, same histologic tissue, if you will, but it's a larger lesion, all right? And these are not self-limiting, still in young patients, still male to female ratio of 2 to 1. You notice, guys, that the Lord has cursed us. We get most of the tumors significantly much more frequently than the females do, with a few exceptions, which I'll point out. Pain is not relieved with aspirin, okay? And in some of these things that show up in the spine, you may get neurologic symptoms. Radiographically, you get a mixed lytic or blastic or sometimes pure lytic picture. And again, the nidus is larger than 2 centimeters, usually between 2 and 6. One of the Henry mechanisms is that these are often blastic in the extremities and lytic in the spine. Remember, a good percentage of them show up in the spine and the sacrum. CT scan, again, can be helpful. Look for matrix, look for thin sclerotic rim around them, and they can sometimes have an aggressive appearance. Here's one that's sort of lytic in the proximal femur. Here's the proximal humerus, somewhat lytic, very hot on bone scan. You can see that it's on the CT scan that it's got sort of a rim around it and it's got a little bit of density within it. Proximal femur, same thing, sort of a rim around it. Notice the density. There's some soft tissue density within this thing, near the soft tissue. Very hot on bone scan. Proximal femur, same thing, got sort of a sclerotic rim around it and has this dark signal on T1. Spine, posterior elements, rim around it, a little bit of mineralization within it, hot on bone scan. Calcaneus, same kind of thing. Rim around it, and some reactive bone. This one's more of a blastic one. Here's an example of one in the pelvis. This is actually a current patient of mine that I'm nursing along. That we took this had been there for years and neglected. Took this out, put an allograft in, tried to debride it, and so on and so forth, and he got a recurrence, which I had to go back and treat. And then he got associated radiation. And now I've got to deal with the problems of radiation. Histologically, the nidus looks the same as the nidus of an osteoid osteoma. Again, irregularly shaped osteoblast, abundant cytoplasm, loose vascular tissue, and you can see some giant cells in it as well. The treatment for osteoblastoma, much like chondroblastoma, giant cell tumor, and all these other locally aggressive benign lesions, is what we call an extended intralesional curettage, which means you open the lesion up, you see every nook and cranny. You don't think, well, I think it's there, I think it's there, I think it's good enough. No, you open it up, kind of marsupialize it in general surgical terms, see every nook and cranny with your own eyes, scrape it out, wash it, burr it back beyond those margins to normal-looking bone, and then some adjuvant treatment. What do I like to use? I like to use phenol. Just paint it with phenol, then neutralize with alcohol. Some people will use those argon, flame-on things in there. Some people will use liquid nitrogen, do a couple of freeze-thaw cycles, whatever you like to use. But adjuvant treatment seems to be helpful in decreasing these things' recurrence. Reported recurrence for these things are 10 to 20%. And this is true of almost all these benign but locally aggressive lesions. However, the fact of the matter is, with adjuvant treatment and current techniques, it's not nearly that high. Now, this is historical numbers, and everybody talks about, we don't think it's any higher than that, but there's no published data yet to show us, well, what it actually is. But my bet is that realistically, reported recurrences are probably about 5% now in most of these things. And just FYI, there is an aggressive subtype of osteoblastoma, which occasionally can metastasize. Don't worry about that for your boards. So here's osteoblastoma. Here again, immature osteoid, right around here, fibrovascular stroma, and then all these osteoblasts here, all right, that are abundant, plump osteoblasts. This is the picture that you get. Okay. Now we'll go on to osteosarcoma. You will absolutely positively see osteosarcomas. Osteosarcoma is the most common primary sarcoma of bone. All right? Myeloma is not really a primary sarcoma of bone. So it's number one. It's common in adolescents and young adults, and there's a second peak in the elderly associated with Pathologic disease. There's several different subtypes, but we're going to talk right now about high-grade intramedullary. That's the most common. Then we'll talk briefly about telangiectatic, parosteal, and periosteal, just so you're aware of those. But these are aggressive lesions. Here's one with lots of mineralization around it in the proximal femur. Here's proximal humerus. Remember Fred Mister's law, proximal femur, proximal humerus, distal femur, proximal tibia. And that's where these things show up. This one's much more blastic in appearance. This one's much more lytic in appearance and destructive. High-grade intramedullary accounts for about 85% of the osteosarcomas that present. They almost always present as stage, remember stage, this is the overall appearance, 2B lesions, which means high-grade histologically, extra-compartmental. Okay? Some 10 to 20% of these present with metastatic disease, which is a very poor prognostic indicator. If they show up and they've already got metastatic disease, it usually goes to lung, sometimes to bone, and about 50% of these occur around the knee. Other common places are proximal humerus and the pelvis. If a person has a skip lesion, just to mention so I don't lose my train of thought, it's the same as presenting with a MET. So a skip lesion is a lesion inside that same bone that's separated by normal appearing tissue between the primary site of the tumor and that lesion. Radiographically, you get a destructive lesion, which is lytic and blastic. Sometimes it's purely one or the other. Almost always there's a periosteal reaction and a soft tissue mass. I'll go back a slide. Notice this Codman's triangle that's formed here, this periosteal reaction. Now, the periosteal reaction, remember, as opposed to smooth, nice formed thing that you saw, dense bone around the osteoid osteoma, you look at something like that and say, okay, that's been going on for a while, that's nice and smooth, the body's dealing well with that. With this kind of periosteal reaction, up here, the periosteum is ticked off, and it's trying to wall back the tumor, back, and putting down a line. If it says it a bunch of times, it says back, no, back again, no, back again. That's how you get the onion skinning, is it fails in its attempt to stop the tumor, falls back to the next line, and does it again. And so you make it 4 or 5 or 6 lines of that onion skinning. That's the cause of it. In this area here, where there is no periosteum, well, let's go down to this. The next thing would be this sort of hair on end thing. The periosteum is no longer lying parallel to the bone, it's perpendicular, it's going back, it's kind of waving perpendicular to the bone, and it's lost. And it forms bone perpendicular, sort of hair on end or sunburst. And then lastly, areas like this, where there is no periosteal reaction at all, the periosteum is just given up. It's gone on vacation because the tumor is so overwhelmingly aggressive against it that it can't respond. So again, that's the bone knows one trick, make bone, but those are different manifestations of how it responds to the tumor that's there. MR the lesion, it'll show you the soft tissue mass, and look for a skip lesion in the bone. You got to image the whole bone, and it's the same as if it presented with a metastatic lesion, prognostic-wise. Finally, mandatory bone scan to check for other lesions, and a CT scan of the chest to look and see if they've got lung mets, which is not that uncommon. So here's a classic appearance of a proximal tibial osteosarcoma. Mixed lytic and blastic appearance, Codman's triangle here, cortical destruction, and sort of soft tissue mass effect. Here's some mineralization and all. Notice that by and large, at least radiographically, the lesion respects the physis. But you'll see on MR that's not true. See, it's broken across here. Very hot on bone scan. Here's a good example of how you see this lesion here, say, okay, it's going to be hot on bone scan, but it's super hot on bone scan. When the bone scan is very, very hot and extends beyond what you see radiographically, that's a bad sign. Something is very, very active and kind of percolating through the bone. And you can see on this axial image here, big soft tissue mass associated thing. Here's where the tibia should be. Here's it's got some mineralized areas back here. You can see the little density there, and even soft tissue formation beyond that. So very aggressive high-grade osteosarcoma. Here's a distal femoral osteosarcoma that is more dense, a little bit of lytic nature to it. And here, not very reactive around here, but increased fluid on the T2 signal. Here's one that very subtle changes here in the distal femur, all right? You see on CT scan, there's some mineralization here and some mixed lytic blastic. Soft tissue mass you see here on the MRI with abnormal signal here. And again, very hot on bone scan. You look at this, you say, okay, that's hot, but it's really hot in a whole area in the distal femur. So classic for osteosarcoma. Now, I'll show that. I'll talk about it in a minute. So here's a good example here of an MR. Here's a T1. On T1 images, you just jot this down in your margin now so you'll remember it. You already told me what's bright on T1. It's fat. What else is bright on T1? GAD, methemoglobin, proteinaceous fluid, and melanin. Those are the only 5 things known to man that are bright on a T1. So if you see something on a T1 image and it's bright, fat, GAD, methemoglobin, melanin, and proteinaceous fluid. If you see a T1 image and it's bright, it's got to be one of those 5 things. So that's the beauty of MRI sequences. T1, those things are bright. On T2, what is bright? Free water. Free water is what's bright on T2. Okay? That's pretty much all that's bright on T2. And then you get a gadolinium study, which shows what? Vascularity. All right? Erythema, or blood flow. So the reason you get, and that GAD is bright on T1. So the reason that you get a GAD study is to show how much hyperemia is associated with the lesion. You fat suppress it so you don't get confused by the bright fat, and there's your sequence. T1 image, a T2 image, and a T1 fat suppressed gadolinium images. That'll tell you, is it fluid, is it inflammation, is it hyperemia, is it edema, so on and so forth. So those are the sequences, and that's why we get these MRIs. It's helpful. That'll be very helpful to you as you look through things. So notice on this GAD image, this is hyperemia in here. It's bright because of hyperemia. And here's a lesion. When we image the bone that's dark, we say, oh, goodness, is that a skip? We actually had to rule out skip, and it was not. He had a small, unrelated enchondroma that you couldn't see radiographically in the proximal femur. Here's another pearl that's going to save you when you're looking at images. When you see an image like this on a T1, fat is bright on T1, if there's something in the T1 that's as dark as the surrounding muscle, as dark or darker, then it's true pathology. So the surrounding muscle is the guide on a T1 image. The muscle is dark. Anything in the fatty marrow signal that's as dark or darker than the surrounding muscle on the signal is true pathology. If it's lighter than that, then it may be just some modest edema. It might be post-chemo changes. It might be red marrow, whatever. But that's your gold standard, is a T1 image and the appearance compared to the signal compared to muscle. Okay, so you can thank me later. That's actually a very useful piece of information. And here, a wide resection. Another osteosarcoma of the pelvis. Again, very hot on bone scan. You can see on cross-sectional imaging there's some mineralization throughout here. And you can see on MRI, look, there's extension into the vertebral bodies and the sacrum on both axial and coronal images, and wide resection. And one more example in the diaphysis here. Mineralization here. The bone looks funny. It looks like it's been destroyed. Mineralization. Now, this isn't nearly as hot on bone scan as I would have thought. And so I looked at this and said, boy, I'm not sure this is osteosarcoma. Here's a PET scan. PET scan is very hot. We're not going to take the talk about that because I don't think you're going to see that on your boards. But in this case, it's because there wasn't a lot of bone reaction to the lesion itself for some reason. Here's the same tumor. Mineralization here, mineralization on the inside, outside the bone, it's bad. Big soft tissue mass, abnormal signal inside the marrow cavity. On the CT scan, abnormal density inside there. It should be the same as fat on a CT. And of course, big, long lesion in the soft tissue mass, T1 and T2. Proximal humerus, same thing, hot on bone scan, soft tissue mass. Here's after resection, allograft reconstruction. If the lesion is big and it's got areas that are cold or photopenic on the bone scan, any lesion that's big and has photopenic areas is suggestive that's either fluid inside there and there's no uptake on the bone scan, or necrosis. So when you see something that is a donut sign, I refer to it as, the central area of photopenia, that's either because it's a very aggressive lesion and it's got necrosis, or because it may be a cystic lesion and there's fluid inside there. That's, again, something that's very helpful in helping interpret what you're seeing on the bone scan. And it's all this information, these imaging studies you put together, that leads you to the appropriate diagnosis. And this one you can see had a big, big soft tissue mass, destruction around here. Here's the distal femur, big soft tissue mass, big resection. Here's the lesion after resection, and we actually did a rotation plasty on this person. This is very, very difficult to sell this anymore. Most people are not that interested where this in a growing child then becomes their knee later on. The only good thing about doing this is that when you're done with a case, and the case can take a while, when you're done with the case, when you pull the drapes off, it's never the same nurse that started the case that ends the case, of course. So you can pull it out, so you can go, I put it on backwards! And they always scream, every single time. It's perfect. All right? As long as the parents aren't around to hear that. So this actually is a very good operation. It's very hard to sell on people. I haven't done one of these in a number of years. Okay, so pain is a common symptom. We already talked about that with osteosarcomas. Histologically, what do you see? You see these tumor cells. See these tumor cells here, and you get the so-called lacy osteoid. You get all this immature pink osteoid that's forming around the tumor cells. All right? They call it lacy because it's kind of, I guess, if you washed out all the cells and you saw what's just left, you'd see these little sort of round circular things that almost like a little lace doily or something. I know us guys, that's not a manly thing to say, but that's kind of where it comes from. And of course, you've got malignant cells that are forming it. Now, these tumors can be chondroblastic, making some cartilage there, osteoblastic, making bony tissue, or fibroblastic, maybe making fibrous tissue. It doesn't matter. If it's still a malignant lesion of bone and making some bone in there, it's all chondrosarc. No, it's all osteosarc. I'm sorry. So malignant bone lesion, it's all osteosarcoma. Now, I'll show you that the chondroblastic lesions tend to be the periosteal osteosarcs, and the fibroblastic lesions tend to be the parosteal osteosarcs. I'll show you that in just a minute. Most of these high-grade intramedullary lesions are osteoblastic, or they may have some cartilage mixed in them. And it's not uncommon to see some giant cells or small cells. Trust me, you'll get the osteosarcoma thing correct. So here's the normal lamellar bone. Here's the abnormal tumor cells. This is all this woven osteoid that's in there that sort of annealed itself to the more normal bone. Here's a big area of abnormal bone, tumor cells. And see these little bits of sort of myxoid stuff, kind of the blue balls, chondroid things. Here's a little bit of chondroid tissue in here. It doesn't matter. It's still an osteosarcoma. Osteosarc, and here's the high-grade area where you've got big, ugly cells, and you can't even tell what it is because you don't really know that there's osteoid there. Osteosarcoma. You're going to know it's an osteosarcoma by the imaging studies they show you and the malignant cells. So this is not a difficult one. Now remember, there's a telangiectatic variant of osteosarcoma, which is essentially an intramedullary, usually metaphyseal, long bone type of thing. Looks very similar to ABC, so watch out. Remember, anytime you think of aneurysmal bone cyst in your diagnosis, you better consider, at least consider, telangiectatic osteosarcoma. Now, it may be totally off the chart, but you better at least consider it. Because these are also lytic and destructive, and have expansile, and not uncommonly present with a pathologic fracture. The difference is, while you see lakes of blood histologically, you get malignant cells around those lakes of blood, unlike ABCs, which we'll show an example of later. How do you treat these telangiectatics? Same way, conventional osteosarcoma. Chemo, surgery, chemo, and they're usually somewhat more chemosensitive, but there's no better survival. So just remember, chemo, surgery, chemo. Here's an example of a lytic one in the proximal humerus. Here's a very destructive one, the distal femur, very, very lytic. And you see all the fluid levels on this MR. Big old soft tissue mass in this thing. Here's one from a couple of years ago. Big, mostly lytic lesion. There's that donut sign I was talking about. Right down here, the bone's hot because there's some more bone that's being destroyed. But mostly, it's not hot because it's mostly cystic. And you can see on MR all the fluid levels here, all these little tiny fluid levels, and a big soft tissue mass associated with it. Here's one in the proximal humerus, big soft tissue mass, all this fluid, very, very hot on bone scan. And this is what you see. You see blood, but you see these malignant cells scattered through there, which you would not see on a ABC. Malignant cells scattered through here. Okay. How do we treat these? We treat high-grade intramedullary osteosarcoma with multi-agent chemotherapy and surgery. So they typically get several weeks of chemo depending upon whatever protocol or whatever treatment modality has been selected by hem-onc guys. Surgical resection, remember, typically limb salvage, and then additional chemotherapy for several months. Now, what you're looking for, and this potentially will be a question, you want necrosis of better than 98%. So you don't go high-fiving when you say, oh, we got 95% necrosis or 90% necrosis, because really it's 98% that's a good prognostic sign. Where you get 80-85% survival compared, if it's less than that, to about 50% survival in the others. Overall survival is right around 60 to 70%, right around that ballpark, which is not too bad. Local recurrence, as we talked about, is a poor prognosis. The literature suggests about 90% of those patients who present with local recurrence end up dying. Again, that probably reflects not necessarily that you did the wrong thing with the surgery, but that the cells are so aggressive, high grade histologically, that they were hiding in what was normal tissue, and it recurred, and it was going to end up bad anyway. Here's just another example of abnormal looking bone, sort of a mixed lytic blastic appearance to it, slightly expansile, little onion skinning here. Something bad is going on. It's a high grade osteosarc. And I showed you this picture before. You want to resect it with soft tissue around it and reconstruct it. Now, the question always comes up, what about a pathologic fracture? It may require amputation to control the disease, but this is controversial. And I really struggle this year with what to tell you. In the past, I've always told people, if they have a pathologic fracture, treat it as if they didn't. But a couple of articles have come out now to say, well, but maybe we should. So hopefully this won't show up on your boards. If it does, my suggestion to you, in other words, if the pathologic fracture that presents in an osteosarcoma, what do? Do you do an amputation or do a limb salvage? If I'm answering the question, and I'll take the heat, you can email me or throw car bombs or whatever, I would still answer limb salvage. So that's my vote on how you answer this year on the board, is that still limb salvage is adequate. There is a potential for local recurrence, increased local recurrence, or maybe systemic recurrence. But I think that there's enough belief that we can control it with chemotherapy and still do an adequate resection that limb salvage is okay. Just recognize, the question may be, what's the problem with pathologic fracture? And they just want to see if you can recognize that the potentially is an increased risk for local recurrence. That's easy one to answer. If they ask you, how do you treat it, then Ted Parsons' answer is limb salvage still. Remember, that includes chemotherapy. That's the most important part. The other thing is that there's this multi-drug resistance gene, the so-called MDR gene, which presents a very poor prognosis. This is a P-glycoprotein pump. There's a cartoon of it over here that actually sits inside the cell and pumps the chemo out. So those cells that have this P-glycoprotein pump are basically saying, hey, feed me. That's fine, no problem. They just metabolize part of it and spit it out, and they don't die. Which is why that about 25% of primary lesions, about half of all metastatic lesions, have been discovered to have this and aren't responsive to chemotherapy. So that's a bad thing. Okay, high-grade intramedullary osteosarcoma. That kind of wraps that up. Now, here's a subtype, parosteal. This is something that shows up fairly frequently, probably every second or third year on your test, is the parosteal, P-A-R-O, osteosarcomas. This is a lower-grade surface lesion, typically on the metaphysis of long bones. It's usually the distal femur, but it can be proximal tibia or proximal humerus. And it's a painless mass, firm and fixed. You may get loss of joint motion because of the mass effect. And it's a peak incidence in the third or fourth decades. This is one of the ones that has a clear female predominance, so it makes it a little bit different than most of the tumors. This is a stuck-on appearance to this tumor. It's usually heavily ossified, usually lobulated. The CT or the MRI may show it encircling the bone almost completely, and about a quarter of the time there's some modest marrow invasion. I'll show you an example. Histologically, you see regular bone trabeculae with some very slightly atypical cells that have fibrous tissue. And hence I told you that parosteals are typically fibrogenic. Okay? So don't confuse this with fibrous dysplasia, because it's a very fibrogenic lesion. Sometimes they even have a cartilage cap, and sometimes people will say, oh, it's a OCE, an osteochondroma. No, it's not. I'll show you an example of the difference so you don't confuse them. So here's a classic example. As a matter of fact, this very picture was on the boards a couple of times. Here is the classic example of the posterior distal femur stuck on. You know, it's the old grade school trick where you don't admit to, but I know you did. You took toilet paper and got it wet, threw it on the ceiling. Okay, it's stuck on there. I know you didn't do that, but you did. That's the same thing. You kind of threw it on the bone, it's stuck on the back of the bone. That's how parosteals look, like someone's thrown it on there, it's stuck on there. On this AP view, you see some mineralization there, which is abnormal because of the size of the lesion. Here's a smaller one from the back that's actually got some intramedullary invasion, but again, it's stuck onto the back of this bone, hot on bone scan, and you see on this MR, nice T1 fat signal here, abnormal where there's a little bit of invasion, and this stuck on the back of the bone appearance for the soft tissue mass. Here it is in gross section. Proximal humerus, all this stuff sort of stuck on the periphery of the bone, normal medullary contents. And this is what you get. You get very bland spindle cells in this, and fairly normal looking bone around here as part of the lesion. And so here it is. You got this bland spindle cells, this bone, and the bone can be fairly lamellar looking. And so this is not fibrous dysplasia. This is parosteal osteosarcoma. Again, this is in your slides, so you'll be able to look at this and compare it to fibrous dysplasia. But don't let the pathologist tell you if you biopsy it that, oh, it's just fibrous dysplasia, because it doesn't look like it. Besides that, fibrous dysplasia never crawls outside the bone and is stuck on the outside of the bone. Never, ever, ever, ever. Fibrous dysplasia is inside the bone. Treatment, wide local resection. Typically, they don't get chemotherapy because they're lower grade lesions and they're not chemosensitive. However, sometimes you can get a dedifferentiated area in it. You wouldn't know that until you had it off surgically. And so if there is an area of dedifferentiation, we do add chemotherapy. All right? Prognosis, however, is pretty good overall. Look at this, 80 to 90% survival rates. So that's good. Now, here's the key. Here's something I want to show you that's going to help you recognize the stuff. Myositis ossificans traumatica is what we call juxtaposed to the bone. It's near the bone, but typically not stuck on the bone. All right? Here it is. On plain film, there's a little bit of space between the bone and the lesion. On CT, you can see there's space between the bone and the lesion. And here's mineralized at the periphery and less dense in the center. Okay? This brings up a good time for me to mention something to you that you got to recognize. The so-called zonation phenomenon of Ackermann. I don't care if you remember that or not, or that it was published in 1957. Zonation is what I'm concerned about here. An osteosarcoma grows how? We talked about sarcomas growing how? Centripetally, right? From small, they start small here and explode out. All right? So when you see a lesion that's got mineralization within it, or the epicenter here and mineralization is kind of coming out, that's going to be an osteosarcoma. Myositis ossificans traumatica is mineralization taking place because you get mesenchymal cells that are forming bone cells in irritated tissue. It happens from the periphery, from the outside in, because you have blood supply from the outside in. So you see in this example here, when the mineralization is at the periphery and nice and solid around there, that's because it's bone forming in response to the trauma. So that's MOT. Here's an example of one in the arm. You see this mineralization at the periphery here. Mineralization at the periphery, soft tissue mass, okay? Nice mineralization periphery on CT scan. That's from the outside in. That's MOT. If the mineralization is from the inside out, it's going to be an osteosarcoma. And finally, in this case, it was pretty good because the history was fooling around, working with the biceps and so on and so forth. You see inflammation up and down along the biceps. This is MOT within the muscle. And here's an OCE. This is, of course, not stuck on the bone, but shares the cortex with the bone for an osteochondroma or an OCE. We'll talk about those when we go to those later. But the parosteal, the differential diagnosis for a parosteal osteosarcoma is typically OCE or myositis ossificans traumatica, because those are the things that sort of happen on the surface of the bone that have some mineralization in appearance. And that's the key to distinguishing the difference between the three. So, clinical pearl. Parosteal osteosarcoma is stuck on the bone. Myositis ossificans traumatica is juxtaposed to the bone, and OCE shares the cortex with the bone. All right? The intramedullary contents sort of flow into the lesion. Okay. That's chapter 3. Let's go to chapter 4. We may get one more chapter done. We got lots to cover after lunch, but the soft tissues go pretty quick. I'm supposed to quit at noon, is that right? Everybody's saying, no, quit now, please. Noon, so we'll go another 15 minutes or so. Okay. Periosteal osteosarcoma. Let's see if we can get into the chondrosarcs before we quit. Periosteal. So we have high-grade intermedullary, which is the most common one. That's the one you're likely going to see. You have PARO, P-A-R-O, parosteal osteosarcoma, which you may very well see because that is one that is distinct among the osteosarcomas. Here's the periosteal or periosteal-based osteosarcoma. Less likely to be on there, but you've got to understand the difference. So second decade, again, female greater than male. It's almost always diaphyseal of the proximal femur or tibia. It's a sunburst lesion. We've already talked about what that means, the sunburst lesion resting on a saucerized depression in the bone. And these tend to be chondroblastic. So the fibroblastic ones are the parosteals, and the periosteals tend to be chondroblastic, cartilage-like in appearance. So here's a good example. The bone is sort of saucerized. You've got some reactive changes here from the tumor, a soft tissue mass, and you can see there's a soft tissue mass on this MR. Notice that the nice marrow contents are not involved in this periosteal. Here's a distal tibial one. Again, lesion against the periosteum. This is starting to invade very superficially the cortex, but by and large the intramedullary contents are not involved. It's around here, right from the periosteum. Here's another one from the femur, from the tibia. Same thing, little saucerization, very hot on bone scan. Little change there, but not yet in the intramedullary contents. So this is a periosteal osteosarcoma. Treat it how? Same as high-grade intramedullary osteosarcomas. Neoadjuvant chemo, resection with chemo. Only about 20% of these metastasize. So it's worse than parosteal, but better than standard osteosarcoma. Just you have to know that there are 3 different subtypes, so you don't confuse them. And histologically, here's what you see. You see these, here's the bone that's reactive. Here are the malignant cells around here. And this is where you see that's causing the Cobden's triangle. And within this, you get chondroblastic cells and malignant cells inside the center of this thing. This is sort of the hair on end that's been raised along the edge of the cortex. Periosteal osteosarcoma. So, sclerotic lesions. When we talk about bone-forming lesions or lesions of the sclerotic, here's the differential diagnosis. So this is what the tumor guy like me has to worry about when you see a sclerotic lesion of bone. There's a huge differential. But the osteoid osteoma, the osteoblastoma, and the osteosarc are ones you're going to get tested on the boards. Osteoma, don't worry about because you won't get asked about that. And here's some other things which you may not see. We'll talk about some of them. Lymphoma, according to metastatic disease, POEMs in myeloma. We'll talk about these. But realize that these are the kind of things that will make bone or show up on bone when you see what's going on that you have to worry about. Notice in here is one of the round cell lesions, actually 2 of them, myeloma, but lymphoma. Lymphoma is one of those very few things that is not a bone-forming lesion, but that gets you enough reactive sclerosis where you look at it and say, oh man, that's kind of fuzzy-looking density through there, kind of percolating through the bone. Something doesn't look right. You must include lymphoma on your differential. I'll show you some examples of those. Okay, let's do this. Let's get through this portion of the chondrogenic lesions, and then we'll break for lunch. So there are several different types. The chondromas, or basically balls of cartilage, can be an enchondroma inside the bone, which is a pretty common lesion, or a periosteal chondroma, which is on the periosteum. Okay, an osteochondroma is that OCE we talked about, that's sticking out of the bone. CMF, chondroblastoma, and of course chondrosarcs. And chondroid tissue mineralizes typically. So when you see mineralization, not ossification, but mineralization within bone, you're typically looking at a chondroid lesion. Or it might be an infarct. I'll show you the difference. I've got an example here very shortly. So chondromas. Enchondromas, inside the bone. Benign cartilage tumors, medullary cavity, commonly in the metaphysis. This is the kind of thing that you see, sort of diffuse popcorn, if you will, mineralization, rings and arcs or popcorn mineralization inside the lesion. It's common in the hands and feet, in the feet, 20% in the femur, 10% proximal humerus. They're mostly asymptomatic. Sometimes they can be symptomatic, and herein lies the rub. Because you say, well, it looks benign to me. You get a bone scan, well, it's not very hot, There'll always be a little bit warm, but not very hot, but the person has pain. Then you're kind of stuck because you've got to figure out what to do, whether it's coming from that or something else. Sometimes you get a palpable fullness in the hand or in the foot because of the slight expansion of the bone. Pathological a fracture in the hand is common, and of course this is a very common lesion, second most benign cartilage lesion after OCEs. So here's a classic appearance of a distal metaphyseal femoral lesion. There's some mineralization within it. You don't see much else going on. On the lateral, you see a little mineralization there. And on the MR, you see on the T1 image, it's dark, and it'll be darker depending on how much mineralization there's in it, okay, and lobular in appearance. And on the T2 sequence, those mineralized spots are still dark, and you get a little bit more wet, but you get sort of a mixed appearance. But notice there's no edema around the bone that you're seeing, bright, wetness around here. And the marrow here on the T1 is fat, dumb, and happy, as I'll say. Sitting in there, it's not doing any of the bone, and so that's an enchondroma. Here's in the hand, you give them in the distal phalanx or in more proximal phalanx. They can sort of fill up the cavity, slightly expansile, and the fracture is not that uncommon. Radiographically, as I mentioned, you get stippled calcifications, rings and arcs, or so-called popcorn calcification. Occasionally, you'll see one that on MRI has that lobular appearance, but there's no mineralization on it, whatever, on plain film, and you can still relatively confidently say it's an enchondroma. If the person has pain, or I'm all worried about this, then I will get a bone scan. If the bone scan is minimally warm, and they're almost always minimally warm. Why are they minimally warm? Because at the periphery of cartilage, you're having a very little bit of endochondral ossification taking place at the very periphery. It's just what the body does to cartilage when it's in the bone. All right? So it's minimally warm. And I'll say, okay, it's nothing to worry about. But you have to worry about, like I put here, beware the calcified lesion with lytic focus. If you see a lesion like this that's pretty well calcified all the way through it, and there's one spot that is now lytic, now you've got to worry that you've got a secondary chondrous arc that's developing. All right? And then if you did get a bone scan, it would be hot in that area, and the person's complaining of pain, and you say, okay, we've got to deal with this. The problem with cartilage lesions is that you do have the problem with sampling error. So you have to take a whole cartilage lesion out. If you say, well, we're just going to biopsy it, what that means to me is you're taking it all out. All right? Now, you may do a little frozen section and ask your pathologist, does this look bad right off the bat? And he say, no, it doesn't look that bad to me. Then you scrape it out. But you still got to get the whole thing out. You just can't take a little bit of it and say, okay, it's fine, it's an enchondroma, because you may be wrong. Histologically, small chondroid cells and lacunar spaces. Myxoid, the best description for myxoid is snot-like. Okay, so snot-like background. You see these blue balls of cartilage. Blue balls, blue lobular balls are either chondroid or, according to Henry Schiller, they're chordoma. So the only thing that give you blue balls are cartilage or chordoma. You guys are looking at me funny. Sorry, that's just the way it is. That's a Schillerism, but you'll remember it. Blue balls, cartilage, or chordoma. And remember that the hand lesions are more cellular. So if you take a biopsy and you tell the pathologist, what is this, without any information, he doesn't know it's from the hand, he'll say fairly cellular, could be low-grade chondrosarcoma. So this is another one of my soapbox things. If you're going to biopsy something, you better go down, show the imaging studies to your pathologist, talk to him, look at the stuff in the scope, and tell him what you think's going on. Because if you just hand him a crumb and you don't tell him where it's from, he may give you a bad call. So you've got to communicate with him. Very, very important. So here's one in the proximal fibula that's got a little bit of mineralization within it, slightly expansile. So I'd look at this and I'd say, okay, well, maybe this is kind of warm on bone scan. Still was an enchondroma. I actually took this out. Here's a proximal humerus one, very common appearance, fairly well mineralized, not symptomatic, warm on bone scan, enchondroma. Same thing again. Stipple calcifications here within this. Proximal humerus is a common location. So what's the difference? One's an enchondroma and one's an infarct. Okay? The enchondroma here has mineralization, sort of the rings and arcs up through the humerus. This is a big one, makes you nervous that something's going on. This is an infarct. It's got the smoke up the chimney kind of whirly pattern up the humerus. If you have a bone infarct, you get free fatty acids that form. You get a soap that forms, a calcium soap that forms in the bone. It sits there. And because as Mencken says, there's no soapase, the body doesn't make soapase, that calcium soap sits there in the intermedullary cavity and stays there, and hence gives you that mineralized appearance. Here's an example of an infarct, and notice on the MRI the bilaterality. So whatever caused the infarct caused it to occur at the same time in this growing bones. So this wispy, kind of a smoke up the chimney appearance. And here's a T1 image. Notice that it's as dark as the surrounding stuff in parts, so it's true pathology. And here's on the T2 image, not very bright. Infarcts of bone, smoke up the chimney. How do you treat enchondromas? Well, most of the time with serial observation, radiographs. If a new person comes into me, what's the treatment for it? I look at it, they're not symptomatic. I may get a bone scan if I'm concerned, but usually you can look at it and say, not a problem, come back, let me check it in 3 months. Check it in 3 months, it hasn't changed, have them come back in a year. If it hasn't changed, periodic radiographs is all that's necessary. I've got lots of patients that follow along like that, okay? If it's changing, if it's getting bigger, if it's getting lytic in a spot, or something else is going on, you got to do a biopsy. You got to take it out. And it can be very difficult to distinguish between a low-grade enchondroma, or rather an enchondroma, and a low-grade chondrosarc, or the so-called atypical grade 1/2, enchondromas. Clinical history, size, and location is important, and the MR characteristics may be helpful. Again, here's the lobular appearance, T1 image of an enchondroma. You got to tell a pathologist where it's from, because if it's from the hand, it's slightly more cellular. It's a periosteal lesion, which I'll show you in a minute, it's more cellular. If it's inside the bone, it's going to be less cellular. They need to know where it's coming from. How do you treat them? Curettage and bone graft. They're very easy to treat, just like any little simple benign process. Now, this is something that does come up fairly frequently. You all remember Olliers disease, multiple lesions, so-called enchondromatosis. The bones are dysplastic. It's often a unilateral kind of thing. Deformity is common. Sarcomatous degeneration approaches 25 to 30% in these multiple enchondromas, or so-called Olliers disease. And remember, here's an example, it's a file example, and remember that if they have soft tissue angiomas associated with it, now it's Maffucci syndrome, all right? So typically there's a question about one or the other of these. And remember that Maffucci syndrome, not only do they have a higher risk of developing chondrosarc within the lesion itself, but almost all of them develop a visceral malignancy of some kind. Whether it's an angiosarcoma or a GI malignancy or something, they get a visceral malignancy. So these people need to be watched like a hawk. The treatment for these people with Olliers disease or Maffucci syndrome is focus on the deformity. In other words, whatever corrective surgery needs to be done to keep them functional, and then watch their lesions like a hawk in case something happens. So here's an Olliers disease, large enchondroma deforming the proximal humerus. Here's one in the tibia, and this is an example of what's called sled runner tracks, when you get these streaks of cartilage coming down that get trapped. It's common in Olliers disease. So here's an MR I just happen to have on one with this abnormal changes here and the abnormal cartilage inside the bone. Here's in the hand, Olliers disease. It can be very severe. And again, blue balls, enchondromas, lobular areas of cartilage, all right? And it can be relatively more cellular than others, and it can have calcification in it, like you see here, this dark. At the periphery, you get endochondral ossification, which is why they're warm on bone scan. Not hot, but warm, and that persists. Okay, periosteal lesions, periosteal chondromas are relatively rare. Almost always when you see them in the proximal humerus. This picture actually has been used two or three times on the boards for the periosteal chondroma. And you see this thing nestled with some calcification right in the cortex. Well circumscribed, punctate mineralization, small mass effect, and so-called saucerization, kind of sort of volcanic erosion into the underlying bone. Pain is common with these. It's probably because you get pain at the tendon insertional sites. And here's one that's nestled up here. You don't see much on plain film. There's some mineralization. On the MR, you see this mixed picture. This is what cartilage or myxoid lesions look like. They have some areas are darker and some areas are brighter, nestled against the cortex. Same thing on this axial image. Here's another one here, proximal humerus, very common location. Here's a less common location, but the same thing in the distal radius. Nestled in the cortex here, some mineralization. Proximal tibia, nestled in the cortex, some mineralization right at the periphery. And histologically, it looks the same as enchondromas, although it may have some increased cellularity. Again, it's important to tell the pathologist where you got that tissue from. What's the treatment? Marginal excision to include the underlying cortex, and then bone graft the defect. You can't leave any of this cartilage behind because the cartilage is already kind of revved up and replicating, proliferating. If you leave it behind, it'll come back. The only thing you have to worry about is it a low-grade surface chondrosarc? Those are usually larger, and these don't have that, what's called cortical buttressing. They don't have that saucerization in the cortex. They have more frank discussion or destruction. They look a little more aggressive on plain film. I think this is the last one on here before we'll quit. Osteochondromas. This is a very common tumor-like lesion. You've all seen them in your residencies. About a third of all benign bone lesions. It's the most common benign cartilage tumor. We think it arises from a cartilage at the physis that grows sideways rather than with the bone. And these are painless masses, frequently found serendipitously, and they may have some mechanical symptoms associated with it. So here's one in the diaphyseal aspect of the humerus. Remember, these are three-dimensional lesions you're seeing on two-dimensional images here. You see it wrapping around, and this other is not projecting out toward us, so it doesn't look like quite so broad. They can be pedunculated or sessile. Here's one growing off the fibula. But notice that the marrow contents inside it are the same as the normal bone. Same thing here. This one was taken out because she was having mechanical symptoms. The lesion shares the cortex with the bone as compared to parosteal osteosarcoma or MOT. We showed the difference already. The intramedullary contents flow into the lesion from around the periphery or from around the normal bone. These are seen in the skeletal appendicular lesions in the metaphysis. As mentioned, sessile or pedunculated, about a third of them around the knee. And the lesions typically point away from the joint. All right, they typically point away from the joint. Here's a pedunculated one. They can get on this T2 here. They have some fluid here that can either be from the cartilage or a little burst that forms. Here we actually see there's probably from a little inflammation in the surrounding bursa. Here's another one here. They can erode into the surrounding bones and be symptomatic. This one's affected the fibula. But again, the intramedullary contents sort of flow into this thing. Here's a large one that's very heavily mineralized from a guy that we saw from Haiti a number of years ago. This is kind of like a cartoon. Sorry, you've got the cows, sir. This thing's sticking out of his arm. He was totally oblivious to this thing. He thought it would go away. And around the proximal femur, they can get fairly large and difficult to get out. But again, intramedullary contents flow into this thing despite this mineralization here that makes you say, oh, something's bad's going on. Well, you know it's not. And not that hot on bone scan. Histologically, you see primary trabeculae similar to a normal physis with a cartilage cap that's thin. Beware of the cartilage cap that's more than a couple of centimeters thick in an adult. That means potentially that it's malignant, and a lesion that's growing in an adult. In kids, they may grow with the child. In an adult, if it's getting bigger, it's not just an osteochondroma. It needs to come off because it's probably got a low-grade chondrosarc. So what's the treatment? Observation or marginal resection if they need to come off, but usually delay it in the growing child. Again, points away from the joint, mineralized there. Here's the causes of painful OCEs. They get bursas, malignant transformation, limited range of motion, neurologic compromise. You know, they pinch on stuff. They can even fracture. And here's the reasons for removal, which is essentially the same thing. And finally, histologically, what do you see? You see a cartilage cap should be less than 1 to 2 centimeters. You see primary trabeculae underneath here, and you see perichondrium. You can't leave the perichondrium on. You have to get the perichondrium off and all this cartilage, otherwise it'll come back. And here are the primary trabeculae just right underneath that cartilage cap. And why does this form? Why does it remain primary trabeculae? That's endochondral ossifications taking place. That's why they're modestly warm. That doesn't go away because it's not stressed. That bone's not remodeled. That thing sticking outside the skeleton, the body says, I don't care if it's there. I'm not going to remodel it. And hence the primary trabeculae persists. So that's why you see that, and that's a giveaway when you're looking at an OCE. What disease process leaves you with primary trabeculae in the bone anyway? If you saw that and I told you that was mid-shaft, or say mid-diaphysis or metaphysis of the tibia or the femur, instantly you tell me the diagnosis is, and assuming they didn't have a fracture or something was healing, what? No, not fibrous dysplasia. Osteopetrosis, right? You don't get remodeling of it. You don't get remodeling of it. You get primary trabeculae, fill up the whole thing because you get abnormal remodeling of the bone. So again, the bone's not remodeled here because it's not stressed. In osteopetrosis, you don't get remodeling of it because you can't. You don't have the osteoclastic activity to remodel those primary trabeculae, and they persist. So again, a little thought about the physiology helps you make the diagnosis. And they can undergo malignant degeneration. About 1% in primary OCEs. If people have what's called multiple hereditary osteochondromas, HMOCEs, it's a higher risk of malignant degeneration. So watch out. If they're growing after skeletal maturity, you've got to watch out. They can develop a secondary chondrosarc. And here's HMOCE. You get the same OCEs, but they're all over the place, all over the bones. This is one child here with different spots that are kind of warm on bone scan. Okay, you guys have got the deer in the headlights look. Any questions before we break for lunch? Thank you very much. This afternoon, we'll go through the rest of the book.